Yes, I believe this works. The song is not needed after all. Good morning, everyone. I'm delighted. The second day. Is this working as it's supposed to be? Okay, good. The second day of the Migrants HIV and Migration Summit. Delighted hearing your stories also of the day where I heard you had a really good meeting. Yes.
Good morning.
Good. Let me do that again. So, again, warm welcome this morning to all of you. It's great seeing you, and especially after having heard the stories of yesterday, where I heard that you had a really good meeting with the communities. And I'm so inspired to see so many people from so many different backgrounds and countries. So in that respect, I'm really looking forward to this second day of the high-level policy roundtable today. My name is Elisabeth Kuiper. I'm a director at the European Policy Center, a Brussels-based think tank. So also in light of what we do as a think tank, I'm really looking forward to today's session with a lot of inspiring speakers and a lot of interactive input from your side, I hope. Because today's overall context isn't very positive, I'd say. We're in the midst of a really challenging multi-level and geopolitical context with a war going on in Europe, with a cost of living crisis, an energy crisis, a looming economic crisis. And we have learned that since COVID-19, health inequalities are actually increasing. And especially for the topic that we're going to speak about today, that is not a positive message. So I believe also, having learned what you discussed yesterday, that for today it will be key to really sort of leave from that bigger geopolitical picture and make today's output very concrete. So I really would like to call on all of you to contribute to the discussions, to be interactive. Please raise your hand if you would like to take the floor. Speak up. Feel free to speak up. And I hope that in that respect, as the chair of today's session, I facilitate indeed a very interactive meeting. So with that, because we are very keen also to hear about yesterday's outcomes, I'm going to hand over to Gary. I believe, Gary Jones, you don't need introduction. You're in the field for more than 40 years, I believe. So 40 years is a long time. But currently you're at UNAIDS, so you're very well placed to do the opening remarks and say a few more words about why we're here today and what the outcome and the aim of today's meeting is.
Thank you, ma'am. Good morning, everyone. It's an almost impossible task because in 10 minutes I've got to wrap up, summarize what was an incredibly interesting day. What I've done, what I've attempted to do, is to capture the main points that we discussed, the ideas on the walls behind you, and the discussions that happened at dinner last night and in the corridors. It was absolutely very engaging, and as we've just heard, please, more of the same today. A few notes, and please do shout out if you think I've wandered off track. First thing I'd like to talk about, we mentioned a lot, was political will. Having the needs, having sustenance, knowing how to speak with political will, having to generate the interest, the desire for change for HIV and migrants. So political will and how we go about making the right sort of decisions at the right time for the right reasons is very, very important. We spoke a lot of community engagement and equity-based approaches as the way to deal with the holistic nature of health, emotional, physical, mental, spiritual, all the various dimensions that make up a human being. And that we also heard that what tends to happen in this current climate is that we lean towards the physical aspect of health, obviously, crucially important, but then given the trauma, the experiences that many migrants have been through, it's at our peril if we neglect the mental health dimensions as well. So a holistic approach, social determinants approach to health in the context of migrants, which is a very changing, very fluid, very dynamic field. We spoke of the need to keep track of what is happening. We heard of the move in so many countries in Europe towards stricter rules, legislation against migrants. For good or for bad, the situation is changing. We need to know that we are on top of the facts. We know all too well that there are many gap areas that we can only assume. We cannot base our collective response on anecdotes, but at the moment it can lean towards that. So there was the crying need for more data, if, as UNAIDS would put it, for strategic information, but basically what is going on. And to know, as I've just said, we might be in possession of all the facts today, but given the highly dynamic context that migrants live in, it may be very different tomorrow. So we need to develop systems of data collection, so that it isn't a case of, okay, well, this time next year we'll have another round then of fact-finding. We are constantly on top of an evolving situation. Okay, we spoke of, if you will, different levels of what needs to be done in the context of a holistic approach to health. We spoke of the individual. We spoke of the environment. We spoke of structural components, all of which are absolutely key in trying to improve access to health. And we also continually reminded ourselves that we have to get real. And I'm quite sure myself, UNAIDS, were as guilty as the next person in thinking high of what the vision, the world. You know, we heard this aim for the stars and you'll end up in the clouds. That's still good enough. But it's a case of, yes, dream big, but get real. Ground it in reality. Turkey was one such example that we heard about, where, yes, good things are happening. And why are they happening? Because it's off the radar. And no one's really speaking of it, and it's just sort of happening, which is good, but is that a systemic, sustainable approach? We need to get grounded in reality and find it. What's happening? We need to, with that political will, make sure that funding is available. Time and again, yesterday, we heard that, yeah, like, this is great, just, you know, look around the walls, the things we were saying, every single thing, it needs a dollar and a cent at some stage. We can talk and we can talk, but to have that real tangible outcome, we need to have the funds. So where are we going to get those funds? Who should be responsible? Again, these are some of the questions that we're kind of like going to grapple with today, with us, again, and with our new colleagues at the table. We need to find out how and in which ways we can make this a reality. Now, just a few more specific contextual issues. We spoke of the need for finding the funds, finding the political will, but then in sustaining. What about fees for using services? Many migrants are forced to use the private sector because they find it too hard, it's too difficult to navigate. Maybe it's an issue of language, of cultural insensitivity. So they may be forced to go to the local pharmacy in a slum area, asking for advice, for example, or a nurse at a transit centre. Should they be paying for that, or should it be not? I think it's fair to say that the mood in the room yesterday was that no fees should be asked for. Again, that's fantastic. But when you're a community-based nurse and you actually also have to have a salary because you've got to pay your way, where are you going to get your money from? So again, trying to be realistic and find out how we're going to tackle that problem. We also noticed an institutional bias against many migrant programs, policies. Speaking out loud, wonderful, but in terms of it seems to be entrenched, whether that's a sort of a national xenophobia against those from outside. I don't know, your guess is as good as mine, but there seems to be this institutional bias. It's entrenched, it goes deep. We have to find out how we can methodically deal with that situation. We need to find out how we can stop doing a siloed approach. Again, in our discussions, it was a bit, oh, I am a mental health specialist. Oh, I deal with migrants in Poland. Oh, I do psychosocial care in Greece. Oh, I do. Fine, we all have our areas of expertise, but we need to speak that horizontal coordination, that horizontal collaboration, so we can really generate that information that we need. And although we said every situation is unique, every migrant is unique, every migrant has their own story to tell, there are commonalities. And we've got to see those synergies and to work on those synergies to strengthen them. Just a few more points. Community. The absolute importance of a community-based response. We know, what little we do know, that in many situations, migrant communities themselves fall upon themselves for healthcare, for social protection, and that they need themselves to work within their own structures. We questioned, well, actually, what is a community? We heard some examples in our discussions that actually when we speak of communities, we quite often talk of the 3 richest men in the village or in the particular group. How can we promote an inclusiveness when we speak of communities? Communities, it's a moral word, it's a wonderful word, but how can we make it so that all voices are heard? The key populations are heard. We heard some very good examples from sex work, for example, of compounding vulnerabilities, of stigma and discrimination. How are we going to address that? And we sort of said, okay, it's intersections, layers of vulnerability. We presumed the example of being gay, being trans, being a sex worker, not knowing the language, coming from outside, not having a dress, on and on and on, and you now talk the language of inequalities. Where do you even start in that scenario? So again, we said, well, it kind of has to start within the communities themselves, but how? Today, we need to dig deep into that particular question. Okay. Advocacy. We all keep saying it, and if you've ever read a UNAIDS document, every other word, if it's not strategic information, it's advocacy. So we all know about it. But what do we mean? Advocacy, it's based on scientific, triangulated fact. We need to know what is happening, so we can then create a message strategy. And we heard some great examples being carried out by community activists in different countries in the region in showing how we can advocate to engender that political will. And very lastly, it was to be careful on our own language that we're using. When we say, oh, migrants, that's right, when we absolutely realize there's 1,000 different classification types of migrant, we must be sensitive to this fact. When we speak of key populations, it's so broad, it's almost meaningless. What do we need when we actually say it? So let's be very careful in the lexicon, let's be very careful in the language that we need. That will feed into our advocacy, that will feed into the outcomes. In a nutshell, That was my summary, and I hope I've kind of done some justice to it of yesterday. Thank you.
Well, many thanks, Gary. Seems very inspirational to me, and it also seems the perfect bridge to our next speaker, who indeed is going to sum up the feedback from yesterday's community session. So, Jacqueline, I'm looking at you, Jacqueline and Nala. It's very hard as well to introduce you because you have such a diverse background and you have such a lot of experience as a human rights lawyer, a lecturer, a board member, an international speaker on equity, diversity, and inclusion. And we are really happy to have you here. And I'm also myself personally very much looking forward to what you have to say in summarizing the main discussion points from yesterday's conversation. The floor is yours, please.
Good morning, all. Elizabeth, thank you for that very generous introduction. I think, Gary, you've done a really good job of summing up. So if I repeat any of that, I'm simply adding color to our discussions yesterday. In the interest of time, I'm going to go straight into it, but just to thank everybody yesterday for really meaningful, impactful engagement. So I think overall, the message that was shared is that ending poverty is key in seeking equity for migrants in accessing healthcare. We seem to be focusing a lot on the symptoms and not the cause. And I think Gary has touched on the major underlying cause, which is government will and the resulting symptoms, which we discussed at some length yesterday. The overall purpose of our engagement and our conversation yesterday was to seek effective collaboration to identify the gaps and fill the theme. So the Mind the Gap theme, I think, really came out really well yesterday. We spoke a lot about the social determinants, poverty, stigma, transportation, storage of medication, hunger, sanitization, overcrowding, lack of a physical address, all the various intersections that really compound this particular issue. We agreed that one size does not fit all. If we look around and see all the shoes that we're wearing different sorts of shoes. And whilst we're having the conversation, I thought of this new meme that is going around. So equality means that everyone is getting a pair of shoes, which is great. But in terms of migrants, not everybody is getting a pair of shoes. Diversity means that people are getting a different type of shoe, which means that different European countries are having different types of intervention. Equity means that everybody is getting a pair of shoes that fits, and would really love to be in that kind of position whereby migrants are getting care that is specific to their needs. And acceptance means that migrants should be able to have some sort of choice about what they're actually receiving. But belonging means that they should not be judged about where they come from and what about their HIV status. And so we spoke a lot about one size that does not fit all. We should meet migrants where they are and not based on where we are and what we think that they require. So a large focus was on the theme of exclusion from healthcare. There were some examples that were given and an illustration about how city slums have got the worst health outcomes. But actually, those in the most precarious situation are migrants in transit centers. And we spoke about the dangers and the hardships faced by this particular group of really vulnerable migrants who, when they show up here, are traumatized and they have got specific needs. We agree that living in environments that are risky leads to risky behavior. And so we really should be careful about the judgments that we throw around because we are all filled with bias. We spoke about the health referral systems, and we held a mirror to ourselves and our colleagues, whereby sometimes health workers, social workers are discriminating against migrants. And as an example of the Rohingyas in Bangladesh. We spoke about the quality of control services with some examples with regards to housing in the Middle East, in Lebanon, Syria, etc. An emphasis on geopolitics, and we all know how this affects equity. A right to work, the dignity of work that is denied to migrants, which could be then locking to a lot of the issues that we are looking at. We've spoken about risky behavior. The first rule of life is survival. So those who cannot join the formal sector because they have are simply going to join the informal, unregulated sector. And they give an example from my own country of origin, from Kenya, where you have undocumented migrants working within construction. They have no contracts, no regulated pay, no health and safety. And this is the risky behavior as a lookout to survive. We spoke about work and the dignity of work. We spoke about how our policies around national health insurance are tied to tax and, in effect, cause more exclusion for migrants. The biggest hindrance is the lack of documentation. On a personal level, it's a loss of identity. On a healthcare basis, it's exclusion. We looked at Christiane and her team's report, and in a summary, it shows that HIV disproportionately affects migrants. There's increased diversity in HIV anthropology. We looked at the fact that vulnerability might undermine migrants, and perhaps language does matter, and perhaps the words that we should be using in this particular setting is precarious, because being in a precarious situation is linked to the social economic status of the migrants. We looked at the research and what was underpinning the research, and there were three significant questions: the burden of HIV on migrants in precarious situations, and which of these groups are most affected, the access to healthcare, and what policies should shape access. Again, this theme of undocumented migrants. And who are the most precarious from those who were surveyed in this particular research? Those who are undocumented, those who are taking injectable drugs, those who were sex workers, and men who were having sex with other men. There was some overall looking at access and the reduced access, but also the continuum of care. And the substantial gaps in that particular report were identified as late access to primary care, lack of prevention, and lack of access to testing. And in addition, exacerbating all of this is the whole stress of being a migrant and being HIV positive, and the impact on this on mental health, which Gary has covered, and so I will move along quickly so that we can get into some formal engagement. We looked at policy and how policy acts as a genuine and a serious barrier, and examples from various countries whereby we've got complex social welfare systems which are understood by few and also just simply add to the complexity and exclusion. We looked at the synergy between various determinants. So we looked at the social economic impact on legal insecurity, with examples around trafficking, transactional sex, sex work, and gender-based violence. We looked at stigma from the community and migrants who stigmatize themselves, the whole issue of discrimination and racism. Let's call it out for what it is. There were recommendations, and by and large recommendations are inclusion, inclusion, inclusion. Change in xenophobic societies, strengthening of community-led initiatives. What connections are we making in this room today? And what connections can we make when we leave this summit? Crucially, it's about leadership and EU leadership, the complicity in creating a hostile environment, and how do we begin to lobby to change this? We went into a Q&A and remark session, and the key theme within that Q&A session was about the precarious nature. Some examples were given from Italy about the delay in getting documentation. And there was some feedback that delay is fine, but often when migrants get the documentation, if they're under the control of criminals and there is no law enforcement, then despite the fact that they are documented, they continue to be in a precarious situation. There was really good steer about educating ourselves, about gender identity and sexual identity and raising awareness. So we have some work to do to ensure that we're continually staying informed and educating ourselves. There was an example from Greece, and it seems like such a long time ago that we had the COVID-19 restrictions, because we're all here in a lovely hotel speaking to each other, having meals together, learning, sharing, and growing. But not so long ago, we were in lockdown. And the effect in Greece, whereby people couldn't leave their homes, and migrants couldn't leave their homes to even access black market work, and the abuse that resulted in. And that abuse hasn't stopped. So the effects of COVID-19 are still being felt today. And we must not forget, as we go about our business, they're still in a precarious situation. A good analogy about the USA and Netherlands, what lessons can we learn? In the USA, there's a right to work for those who are waiting to be documented, whereas in the Netherlands, you only get 6 months, and after 6 months, how are you supposed to survive as an immigrant? And so the Q&A really focused largely on the precarious nature. We looked at case studies, and the case studies were from the Mi-Health organization, which is an HIV partnership between 10 different countries, whereby they share case studies, but crucially, they're sharing learning. And we had the privilege of hearing case studies from 4 different jurisdictions. We had Filomena and Paula from Portugal, who spoke about working with South American migrants. And their goal, really straightforward, one focus, increasing HIV testing. Their strategy, where do you find, we always talk about hard to reach people, but how are we actually reaching them? And the innovation of going to sex adverts in journals, finding the details and making contact with those that they want to contact. Crucially, what was a really good learning lesson here was that this particular group in Portugal were doing testing in the participants' own houses to ensure confidentiality and just to create a safe environment. So some lessons to be learned there. It was really good to hear about their stakeholder prioritization. Often when we sit in these rooms, we speak about ourselves working in the community, but the key stakeholder other immigrants, and therefore in Portugal, the stakeholder trio is a participant, the migrant, the nurse, and the psychologist. So in these conversations, we must always center the conversation around those who are affected by this particular situation. And apart from the testing at the immigrants' homes, there is also accompanying them to appointments to collect medication as a way of enabling them, not empowering them. Again, language really matters. And questioning data. So the data in Portugal, the official figures show that 40% of immigrants are living with HIV. But this particular cohort showed that it was 2% living with HIV. So some questions about the reliability of data, the gaps in the data, etc., is something for us to be weary upon and something for us to think about. Let's continue to mind the gap. And then we had Kim, who shared a case study from France. And it's PAST. And PAST stands for Prevention, Action, Health for Transgender. And although they've been dealing with the transgender community, there's now a move to focus on LGBTQIA+, and also on single parents. The services provided is a holistic approach, providing reception services, domiciliation, which is provision of an address. Without an address, you can't get access to services. So really practical but impactful intervention. Prevention through distribution of condoms, PrEP, assistance with access to get health cards, support for those who are most vulnerable, those who are in prison. And they have added vulnerability, social administrative services, food and sanitary packages. So a holistic approach from our partners in France. And then we had Belgium, and Belgium has been a fantastic host to us, and actually our host is right here. And Luca shared with us the work that is being done by the European Sex Workers Alliance. It's a network of more than 100 sex workers organizations in Europe and Central Asia. There is strength in numbers. I'm a human rights lawyer. I'm on my own. How much change can I really make? I'm a limited resource. If any of you ever have the fortune or misfortune of receiving an email from me, the bottom will say, if you want to go fast, go alone. If you want to go far, go together. The importance of collaboration and partnership that we're seeing in Belgium with this European Sex Workers Alliance. And the acceptance that migrants are diverse. We're not just one monolith. And so therefore we must meet people where they are. Again, data, data, data. Lack of data, inaccuracy of data. Let's continue to mind the gap. In this particular group of migrants within sex workers, they don't access healthcare owing to fear of the police and immigration. And I can definitely relate to that. In the United Kingdom, the NHS are supposed to inform the Home Office about undocumented migrants. So there is really genuine lack of safety. Sex workers will not report crimes owing to discrimination and further victimization by those who are supposed to protect them. This is a law and order problem. And we encourage the academics amongst us. We value your work, but we must encourage you to work with the communities so that we can have reliable data that will inform funding and support. And in this particular context, there is a huge barrier in funding. Then we went to Greece, and we heard from Ian Robert, and he spoke about the impact of leadership in creating a hostile environment. And I think the Greek are learning from the UK. A lot of the restrictions that are put in there is really negative role modeling. And so the current government ran a very powerful manifesto whereby they promised that they would have stringent laws to deter immigrants coming into Greece. And they were true to this. How quickly leadership can move. Within 1 month, they had changed the law. So if you applied for asylum, you would be rewarded by 25 days in detention. Who is going to go for that? Prior, we had universal access to healthcare. Now we have limited access, and once it expires, then you're left high and dry. There was a right to work. There is no longer a right to work. You get a stipend of 250 euros every month. It is not enough to live on. In addition to that, to be able to become a citizen, you must speak Greek before you qualify for documentation. Exclusion, exclusion, exclusion. We would like to see some Greek people speaking in Kiswahili. Let's see how that goes. There was also revoked humanitarian protection for those who have got HIV. Actually, I was quite surprised that people are still getting humanitarian protection if they have HIV. I'm a human rights lawyer. The last successful case that I had was perhaps in 2003. There is great disparity. And so whilst the UK is seen as a great safe haven, I think the data might show you different. So data, data, data. And Ian didn't just speak about the obstacles illustrating the hostile environment against immigrants. He offered some suggestion. And some of those suggestions were largely around documentation, awareness, prevention campaigns, and a reminder to our leaders that we do have the SDGs. And really this hostile environment means that they will not be able to achieve SDGs. We went into a Q&A session, and again, focus on racism being pivotal in exclusion. Gender and sex biases are also other limitations. A question was asked about, try and see if I can summarize it. How do we leverage relationships with government and agencies to make change? That question was not answered, because it does seem that government is the largest obstacle. And so perhaps today we'll take a moment to see how can we work with this hostile environment to lobby to create change. Then we went into focus groups in the afternoon, and we were in 3 different groups. And we looked at access to healthcare services, enabling our policy environment, strengthening community involvement and resilience, providing holistic services and data for change. Overall, the agreement from the various focus groups that we need to focus on the underlying issue. And those underlying issues are lack of immigration status, poverty, and inequity, including discrimination and racism. And we the symptoms, while we might, there has to be some work at looking at what is underpinning all of these symptoms. So in terms of suggestions from various groups, access to healthcare, there should be universal access to healthcare for all, and there should be a unified approach throughout Europe. There should be training around cultural competency, and there should be compulsory training. There should also be training to tackle xenophobia, racism, and to really push for diversity. There should be some focus on understanding structure and infrastructure, and that would be training, capacity building for service providers, but also for migrants so that they can be empowered and enabled to understand the systems that they have to navigate. We should have resource centers, funding, training, free access to medication, treatment and testing. And crucially, we should have the table. There is no point of having these conversations if the key stakeholders are not present. Going further, look at enabling policy environment, encouraging diversity, organized collective, that is organized community work, lobbying of policy makers, seeking policy making roles. How many of you are going to apply for policy roles? How many of you are going to support migrants to apply for policy roles? If you're not at the table, you are on the menu. Data protection laws. We need to change the narrative of looking at migration as a problem. Migration is a solution. We have a tremendous labor shortage in this country. If we began to look at migrants from a business case in terms of the skills, values, and expertise that they bring to our countries here in Europe, then that is some of the unlocking. So we need to be able to reframe the narrative from a problem to a solution. And part of this is expedition, efficiency in terms of validating migrants' qualifications. I'm just going through my list so that I don't repeat. In terms of community engagement, strengthening community involvement and resilience, again, focus on primary stakeholders, involving migrants in decision-making, mitigating stigma, meeting the community where they are, and this might mean engaging faith leaders. So who's got access, work with them. There is no point of me of trying to get access in Greece. I'm not in Greece. I should be speaking to Ian. So often this is about partnership, working, reaching out.
Jacqueline, if I may, I think you had a very rich session yesterday, so probably indeed we could really extend this more, but perhaps at some point
I'm coming to an end. So in terms of the focus group, the conclusion was focus on the underlying issue, lack of immigration status, poverty, looking at inequity, discrimination. Focus on the issue and not just the symptoms. Reframing the narrative so we can have value on all migrants, the business case. We should look to enable and not empower. We must dignify immigrants. And we must focus on those who are in the most precarious situation, and therefore data is really important in dealing with this. So thank you very much for your useful contributions. And I think we're now up to date with all that happened yesterday, and I'm sure we're going to have really meaningful discussion. Thank you for listening to me.
Well, thanks to you, Jacqueline, for summarizing what really seems to be a very rich day with a lot of elements that I'm sure that come back later today, also during the discussion that we're going to have. And I think especially what you said about the need for European leadership is an element that I think we would like to bring back. The next speaker will speak about an element that also came back from yesterday's discussion a lot, and that Gary already told, strategic information, aka the need for data. So I'm very happy to announce Timur Nouri from the European Centre for Disease Control. Timur, you are an expert on monitoring and evaluation, so you're very well placed to indeed give us an overview of surveillance and monitoring of HIV data. And you are the primarily responsible at the European Centre for Disease Control for monitoring the HIV response in Europe and Central Asia. And with that, I believe your slides are up, so we're very much looking forward to listening to you. You have the floor, please.
Thank you so much. Thank you. So I'm super honored to be here today. I'm going to be focusing a lot on the data issues that we've talked about already. I'll start by putting in the context of the SDGs. I'll say a few words around the epidemiology of HIV in Europe, a few words on PrEP implementation in Europe and how that isn't reaching migrant populations. Zoom in on the 1990 targets, zooming in again on how migrants are performing against these targets, and try and answer the question towards the end whether or not we're on track to end AIDS by 2030. So you're all very familiar with the Sustainable Development Goals. Goal 3 is related to health. Goal 3.3 is where we talk about ending the epidemics of AIDS and other infectious diseases. Now, UNAIDS is the global body that is defining what it means to end AIDS. So these are the SDG global targets to see zero new infections, zero deaths, and zero discrimination by 2030. And they developed so-called fast-track targets by 2020. And these are big building blocks. Under each of these, there's lots of other targets. Under this one, on the incidence target, they talk about reducing new infections, reaching at least 3 million people with PrEP, and achieving these 90 targets. And together with the stigma on the bottom, these are areas that I'm going to be touching on going forward. So let's start with a surveillance report for Europe and Central Asia that we collect together with our colleagues from WHO Europe. So in this report that was published last year for 2020, we estimated that 2.2 million people were living with HIV in this wider European region. We saw 104,000 new people who were diagnosed with HIV in 2020. The new data is being published in the next couple of weeks for 2021. But these 104,000 cases are not distributed equally. So 15% of these diagnosed cases occur in the western parts of Europe, so the countries in green. 4% of these diagnosed cases in the center, and 81% of these diagnoses in the eastern parts of the region. And you see the rates per 100,000 population at the bottom, so the true burden really is in the eastern parts of the region. Looking at the routes of transmission by sub-region, they are quite similar for the west and east, so approximately 50% of diagnosed cases occur among men who have sex with men, followed by heterosexual transmission, and only 4% among injecting drug users, whereas in the eastern parts of the region, transmission occurs mostly among heterosexual men and women, and a significant proportion among injecting drug users, and only, let's see if I can move that picture here, 3% among men who have sex with men. A big distinguishing factor is this issue of migration. So more than 50% of diagnosed cases in the western parts of the region occur among people who are born abroad. That drops to 13% in the center and only 1% in the east. So looking at HIV diagnosis in the EU only by route of transmission, we are seeing declining trends now over the past decade in all transmission modes, which is really promising. This issue around the declines in trends in 2015 among men who have sex with men is really positive. That's something that we've been looking for a long time, and this seems to be sustained. But if we break this down by transmission mode and migration status, we see here two lines. The solid line is heterosexual transmission among those who are not migrants, and the dotted line, heterosexual transmission among those who are born abroad, migrants. So the first thing we want to note here is that migrant heterosexuals actually are affected more by HIV than non-migrant populations, even though they only account for 15% of the migrant population in the the European Union. But we are seeing declines in both groups by approximately 23–24%, which is promising. If we look at sex between men, we see a decline among non-migrant men who have sex with men, a 40% decline over the past decade, but that we are not seeing in this blue dotted line where we're actually seeing a 30% increase. So we are seeing declines overall of HIV in the EU, except when it comes to migrant MSM, where we're seeing a significant increase. So despite this overall trend that we're seeing declines, migrants account for 44% of all diagnosed HIV cases in 2020 in the European Union, so a significant proportion. So if we want to see elimination in our region, we must target our interventions to migrant populations. Again, this is not distributed equally. So in the red box here, you see the 44% in the EU. All those countries above have higher proportions of migrants. So this is data from 2020. So if you look on top, you see Sweden, Iceland, Ireland, etc., where more than 80% of diagnosed cases in 2020 occurred among people who are born abroad. And we started coloring these regions differently because it's really important that we look at where these migrants are coming from. So from Sweden, approximately half of the migrants come from sub-Saharan Africa. But this looks very different from country to country. So it's super important that we look at where migrants are coming from in order to tailor our prevention programs to these populations. So where do migrants acquire HIV? This is something that we've looked at over the past decade, and it's really, really important. You are all aware of this, but this is important messages for policymakers and people that we sometimes communicate with. So this is research from Fiona Burns in more than a decade ago, where from the clinical level, in the UK, they estimated that approximately 7% of black Africans who were diagnosed with HIV in the UK were estimated to have acquired HIV after they arrived to the UK. And this increased to 18% by 2010. And she challenged this and said this is based on clinic-based estimates on the doctor-patient relationship that the doctor underestimated, and they weren't comfortable talking about sex. So she challenged the Public Health England to come up with new estimates, more objective methods. And this is something called the CD4-based method, where they look at CD4 count at time of diagnosis. So as you know, the longer you live with HIV, the less your CD4 count is going to be. So you can look at a person CD4 count at time of diagnosis, and if you have information on when they arrived to the country, you can assess whether that person was infected before or after they arrived to the UK. And looking at this more objective method, they estimated 3 times higher numbers. So instead of 7%, it was 24% who acquired HIV after arrival to the UK, and that increased to 46% in 2010. This number is now above 50%, I believe, in the UK. We have done research across Europe to look at this as well, to see if this applies to other European countries. Julia Dalamo and Fiona Burns led an AMAZE project looking at 9 European countries, where they estimated that 63% of migrants who were diagnosed with HIV in these 9 countries acquired HIV after arrival to these 9 countries. So after arrival to these 9 countries. And those who were particularly vulnerable were other European migrants, migrants from Latin America and Caribbean, as well as men who have sex with men and people who inject drugs seem to be particularly vulnerable. If you look at the 9 countries, estimates you see here, particularly in Netherlands, Spain, and the UK, very high proportion of migrants acquiring HIV after arrival to these 3 countries. We've done research at ECDC as well with additional countries, and we're seeing a similar trend across countries. So this is something that we're not entirely sure all policymakers and even surveillance people in countries, people who are working on HIV programming, are aware of. I think historically, people have thought that migrants come to Europe already infected, but actually a significant proportion are not being reached by prevention and testing programs and being in very vulnerable situations. So really important that we continue informing our prevention programs around this. So why is this important? Well, you know, ECDC has been asked by countries to develop screening guidelines after the 2015 migrant crisis, and now with the Ukraine situation, we typically get questions, which infectious diseases should we screen for, and what vaccinations should we provide? But from the HIV side, we know that many migrants are vulnerable to HIV many years after arrival. So screening is going to not capture a significant proportion of those, we have to do continuous testing many years. So we think that countries should really develop and deliver targeted primary prevention programs reaching these populations. On PrEP, so this shows you the status of formal PrEP implementation in Europe as of October last year. We're just analyzing the new data. So as you see here, 22 countries in dark green have made PrEP nationally available and fully reimbursed. 13 countries in light green have made generics available, not fully reimbursed, so out-of-pocket spending anywhere from 30 to 70 euros a month. And in blue, we see countries that have not formally implemented PrEP. And we see in the white dots and the red dots that even during COVID, we've seen 10 countries that have made PrEP available, which is really positive. What this shows you is populations that are eligible for PrEP across Europe and Central Asia. And you see here, out of the 30 countries that responded, the vast majority make it available, eligible for men who have sex with men, transgender people, etc. But no country is actually specifically mentioning migrants. They may be in all these other groups, but unless you specifically target migrants for PrEP, I'm not convinced that they're we're doing a really good job. And we know that from the data we're getting, even from France and Norway, which have the two programs, PrEP programs in Europe, the long in the EU, they are really struggling with reaching migrant populations with PrEP programs. So this is something I think we need to work on a little bit more. So moving on to the 1990, you're all aware of these targets. I won't go into them, but I'll show you some of the data that we have around these areas. So this shows you, we talked about data availability. So this is not outcomes, this is about the data availability on the continuum of care for the general population in green and all the other key populations. So at the bottom, you see the countries to the left with no data at all, people living with HIV, those who are diagnosed, on treatment, violence suppressed, and countries that have data on all 4 stages of the continuum of care. So it's a busy slide, but the key message here is that in green, you see that many countries have got data now on the continuum of care for general population, which is great. That's what we focused on. But less countries have data on key populations. And in orange, you see here that 44 countries have no data at all on the continuum of care for migrants. And when it comes to which countries have data on all 4 stages of the continuum of care, 40 countries for the general population, only 4 countries for migrants, 4 countries have data on the continuum of care for sex workers. So this is a major gap in our data and our understanding of the continuum of care that we need to be focusing on, and we're trying to support countries improve these estimates. So looking at the data availability specifically for migrants now over time, is it improving? You see here on the left-hand side, 2018, 2020, and 2021. And actually what we're seeing is less available data over time. And now these are particular years, 2020 and 2021, with COVID. A lot of attention is being pushed away from HIV to work on COVID and other issues. But this is a worrying trend. I think we're seeing UNAIDS, WHO, ECDC, that it is difficult to keep this on the agenda, and the focus of HIV is shifting, and it's a bit worrying. So we actually need less data, which is worrisome. We'll see how it looks for 2022. This is data we're analyzing right now. So looking at the data we do have, so let's start with this first one. It looks at the percentage diagnosed out of those living with HIV. So we have 6 countries that have data on this. We see UK, Austria, and Portugal have reached this target by 2020. So this is data reported in 2021, but it's for 2020. Luxembourg has almost reached this target, whereas Czechia and Greece haven't. So out of those that are diagnosed, this issue of late diagnosis is really important. We haven't seen any improvement in late diagnosis over the past decade. And what you see here of the total EU population who are HIV positive that have a CD4 count at time of diagnosis, more than half are diagnosed late. You see in blue that migrants are actually, I'm not going to say perform better because it's still almost 50% that are diagnosed late. But migrants a little bit better, and in green you see where they're from, which regions they're from, and it seems to be migrants from sub-Saharan Africa and from Southeast Asia are diagnosed later than other migrants from. Important information in terms of targeting or testing programs. So what do we need to do? We need to reduce the time from HIV infection to diagnosis. And we've done modeling at ECDC that shows you that the median time from infection to diagnosis is 3 years. So that's a long time where you can transmit the virus. So what do we need to do about that? We really need to increase our testing programs. I'm not going to go too much into testing, but just to show you here that there are still some countries in Europe that are restricting access to testing for migrant populations. I think it's 6, 7 countries here that actually have policies in place which are restricting testing for especially undocumented migrants. I'll come back to the treatment issue a bit later. So the second graph on the right here, once you are diagnosed, are you getting treatment? Are you accessing treatment? Here we have data from 8 countries. 5 of them have reached the target. Greece particularly is quite far away from reaching this target. So what do we need to do about treatment? We need to initiate treatment as soon as possible. In 2014, the policy was to start treatment at 350 cells. With the START trial, both WHO and EACS recommended treatment as soon as you've been diagnosed. And most countries now have adopted policies to start treatment as soon as possible, but they haven't implemented these programs. There is one group, undocumented migrants here, who are not entitled to treatment. In more than 50% of countries, migrants don't have, undocumented migrants are not entitled to HIV treatment. So this is a group that will not be reaching these targets going forward. Moving on to the last 90, once you are on treatment, are you reaching viral suppression? So 7 countries data here, 4 of them have reached the target. Austria here is quite far away from reaching this target. So once you reach these 90 targets, at least 73% should be virally suppressed. So again, we come back to only 4 countries have data on all 4 steps. So only 1 country, the UK, has reached this target, the 73% target among migrants. 3 other countries have data, the rest don't have any data. So it comes back to data, as we heard before. So looking at the continuum of HIV care for migrants in the countries with available data, we see here that 71% of those are virally suppressed. And comparing that to the general population in the same 4 countries, we actually see that migrants are performing much worse than the general population in these 4 countries, significantly worse. And finally, on the issue of stigma, it's an issue that we've had major gaps on up until this year, where we did a survey together with AIDS Action Europe and European AIDS Treatment Group for the some data, and I'll just show you one slide. It's data that we're still analyzing, but it shows you the experiences of stigma by key populations. And you see here MSM, migrants, people who inject drugs, sex workers, and prisoners. And we see the experiences. And we see here that migrants are between 1 in 5 and 1 in 4 migrant people living with HIV have experienced these stigma experiences on the right-hand side. So that's something that is not good at all. It's the first time we have baseline data, and we're going to be monitoring this going forward to see if we have any improvements. So to conclude, are we on track to end AIDS? I think, zooming in specifically on migrants now, I think we will be not reaching these targets unless we address certain gaps. And one of them is this prevention gap. So I talked about that the significant proportion of migrants are acquiring HIV after they come to the EU. So we really need to address that issue. We need to be scaling up primary prevention programs, including PrEP and PEP. We have a testing gap. 1 in 5 people living with HIV in Europe are unaware of their HIV status. 50% are still diagnosed late, and migrants don't have the same access to HIV testing as other populations. We have a treatment gap. 1 in 3 people living with HIV are not on treatment. Most countries have adopted these policies to test and treat, but many are not implementing them to full scale. And still 50% of countries are not providing treatment to HIV-positive undocumented migrants. And finally, on stigma, something that we've not had data on before, but we do now see higher levels of experienced HIV-related stigma among migrant communities, among many other communities as well, but particularly among migrants. So to conclude, we are seeing declining trends of HIV diagnosis among heterosexual migrants, but not so when it comes to migrant MSM. A significant proportion of migrants acquire HIV many years after arrival to the EU, and therefore we need to develop primary prevention programs targeted to these populations. We see a very low uptake of PrEP among migrant communities, and that's something I know countries are working on. It's quite difficult, so any support you can give to your national governments or PrEP implementers, the better. I hope we have some time to discuss that here today. This issue of data along the continuum of care is really problematic when it comes to migrants. Only 4 countries out of 55 have data on all steps of the continuum of care. But for those countries that have data for the steps, migrants have significantly lower viral suppression rates compared to the general population. But we shouldn't read too much into this. It's only 4 countries, but still it's not looking good. And finally, subpopulations of migrants have HIV prevention, testing, and treatment services and may be left behind in Europe's efforts to reach the Sustainable Development Goals. So great data we get from many countries across Europe and Central Asia. Too many to acknowledge by name, but and also some colleagues from ECDC, WHO, UNAIDS, and some consultants we're working on. So thank you very much for your attention.
Thank you so much, Timur. As you say, data is key for awareness and understanding issues. So in that respect, we're very happy to have you at the start of this day to really also dig deeper into some of the underlying root causes that you mentioned. Given the fact that we're keenly aware of your need for a coffee break at some point, we made some changes to the program. So we have asked our colleagues Gonzalo and Luciano to go to the second part of this morning session. And I believe everything is now set up for our speaker from UNAIDS, because we have Victor Bampu with us. He is head of UNAIDS Global Fund. And I'm looking, because he will speak to us online, so I'm looking to see indeed if he will be joining us online shortly. Well, Dennis, I'm looking at you. I believe we're trying to get Dr. Victor Bampu online. Perhaps we can ask the speaker to start a video, because I'm not sure whether the video is actually on. Good. While we're solving some of the technical issues to get actually a face to our next speaker, I'm just looking at Isabel. Would you mind, while we're... I think the speaker's getting in. Dr. Victor Bampu, are you hearing us? Are you trying to get in?
Doctor, can you speak?
Yes, the sound's gone off.
So the sound's gone off again. IT issues. Can you believe it? After 2.5 years of working from home, we still have IT issues. But it's also great that we have some people to solve them. So I believe and I'm confident that we will see our next speaker shortly. Yes, that is great. So Isabel, bear with us. We're still having you at a part in the program you were foreseen. Dr. Victor Bampu, we're very honored to have you with us. Also, many thanks for your availability rather last minute due to some changes. You are the head of the UNAIDS Global Fund, and we're very keen to hear what you have to say, and especially if perhaps we can get you up a little bigger so that we actually can see you. I think that would be most convenient.
Yes. Please, doctor, can you speak?
Can I just ask you, Dr. Victor Bampu, do you hear us? I believe due to the fact that you're writing.
Can you speak this?
Yes, can you hear me?
Yes, great. We can now hear you. Thank you so much, Dr. Bampu, to be with us this morning. I was welcoming you, but I'm not sure whether you actually could hear us. So let me do that again. Again, we're very honored to have you with us, especially given the rather late notice, because you're replacing one of the speakers we had. But you are from UNAIDS, the head of the UNAIDS Global Fund. And again, we're very honored to have you with us. So I hope that you can see and hear us well, and I would be very keen to give you the floor.
I can't hear.
You still can't hear us.
I think you need to unmute the Zoom.
My name is Dr. Bampu. As you can see, I'm not Amon. I have been asked to Amon Murphy, who had to excuse himself for something. He sends his regards and share a few with you. And of course, my colleague Harry is also in the room with you. So we'll do this together. So essentially, he's asked me to share a few things. So I'll be doing that right now. Everyone everywhere is entitled to the best possible health care. And that's an easy enough fact to state and pivotal to ending AIDS. It's the most fundamental of human rights and on which healthy lives and livelihoods and robust national economies depend. We need to keep reminding ourselves of this fact, and as many times as necessary to obtain universal health coverage. The Global AIDS Strategy, remember the 2021 to 2026 End Inequalities, End AIDS strategy that the whole world signed up to, speaks very plainly to this point. By you, danger. That if we do not act now, we may well see a resurgence of the epidemic and affecting those most at risk, including migrant populations. You know better than I do that migration is complex and we need to be careful in our use of terminology and to identify exactly population cohorts at a heightened risk of falling outside of healthcare. Of particular concern to UNAIDS is forced migration, increasing globally, with Europe often the destination for those displaced. We should be prepared to see an upturn in forced migration and outward mobility from countries facing high HIV. I'll go back to the Global AIDS strategy that demonstrates how to realize and sustain rights for all, inclusive of refugees, asylum seekers, internally displaced people, and migrants. Now, you will recall that the Global AIDS Strategy actually works with an inequalities framework and puts people at the center. And with the year of 2030 fast approaching, you remember that that is the benchmark year for ending AIDS. We need to undertake proactive action for migrants, including here in Europe. We've heard much of the need for rights-based legislation inclusive of migrants, and UNAIDS supports this wholeheartedly. UNAIDS supports this position wholeheartedly. Already in many countries in Europe, laws exist which promote inclusivity and accommodate everyone living or in transit within national borders. For example, as shared in the recent Fast Track Cities conference, the practice in Andalusia in Spain, in which migrants enjoy same rights as everyone else, given a health card, and in which providing an address is not required, oftentimes this is a sticking point for the homeless migrant constantly on the move. The EU is to be commended for its insightful approach to improving healthcare across the continent. An ongoing consultation for revising policy and seeking to unite and find common ground across national states is to be applauded. Pursuing the commonality of treatment regimens is a case in point, and ironing out questions of intellectual rights and indeed dealing with issues relating to big pharma and the profit margin. UNAIDS' position is clear for the goal of EU health policy: universal and immediate access to quality assured and sustainable health services. Sadly, conditions in which some migrants live have been described at this conference and in other places as subhuman. We know that to end AIDS, we must do so through addressing all sorts of inequalities, by adopting a holistic approach in dealing with the social determinants of health. Migrants and residents alike must never have to decide between health or food or shelter, but that's often the case. And socioeconomic factors, therefore, remain of major concern to UNAIDS. We also endorse the principle of the minimum standard of healthcare, appropriately established, starting with primary healthcare at the community level, quality assured and delivered in an efficient manner with the full participation of users of these services. That's very important.
Get the heater around that, please. EU regulation, so.
Yeah. Dr. Bambu, it seems you're freezing. Could you still hear us? We speak.
Can you hear us?
Where's Dr. Bambu? Even my mic is now.
Is what?
We're halfway through.
Okay. Can you hear us?
Dr. Bambu, can you hear us? Yes, great. You were gone for some point, but now you're back.
Yes. So I was saying that as has been made plain in the Global AIDS Strategy, we need to promote innovative forms of healthcare that are community-driven and patient-centered, and support a One Health approach to meet the needs of all persons, regardless, for example, of political status. And in agreement with our partners, UNAIDS advocates for impactful research that demonstrates the link between health security for all and human mobility, regardless of circumstances. UNAIDS also actively participates and, where necessary, leads in generating strategic information on improving community health resilience, be they host or migrant above all. There is much to do, but together we can. And I recall that an earlier speaker spoke about something. She said, if you want to go far, we go together. This conference is an essential building block of all the things that we are trying to achieve. And my hope is that we'll move forward, reach consensus, and end AIDS. Thank you very much.
Thank you very much, Dr. Victor Bambu. It was a pleasure and an honor to have you with us, and especially given your availability at such a notice to replace Dr. Murphy. And I think also Dr. Bambu provided a really good bridge to our next speaker, because you spoke about a One Health approach, and especially At the European level, that is a policy that indeed the European Commission has been leading now for quite some time already. The importance to link planetary well-being to human health, animal health. And in that respect, it is very good to have Isabel de la Mata with us this morning. You are Principal Advisor for Health at DG Santé. And again, given the recent changes in DG Santé, I think you are very well placed to be with us today and shed light indeed on the step taken in national policies and what the European approach has been so far. The floor is yours, Isabel. Yeah.
The light. Okay.
Switch.
Yeah, better. Okay. So the key challenges, such the access to testing and treatment, the stigma, fundamental rights, are a global problem. And reaching the Sustainable Development Goals is an appropriate framework. The Commission supports the European Union member states in this endeavour and also works with countries outside the European Union. That is also one of our policies. As the displacement of people from Ukraine escalates, it is imperative that countries across Europe receiving these displaced people are prepared to ensure high standards of HIV prevention, treatment and care. So we are aware that we are talking not only about the people displaced from Ukraine, but also about migrants and refugees in general. But in the last time, the main worries and the main burden of the migrants arriving to the European Union have been the people displaced from Ukraine. So we have been paying a special attention and providing the access to healthcare to those people that are increasing as we speak, that the ones that have received the temporary protection directive at this moment are around 4 million people, and 4 million people in since the end of February, so a lot that we are trying to take care of. So the Commission has followed how the implementation of the temporary protection directive that was approved many years ago in 2001, but was a resolution by the Council was passed in March, providing the access to healthcare in specific conditions, but quite quickly for the people displaced from Ukraine. And all the member states have receive the entitlement to access to healthcare and broader range of services that what the directive said. The directive said that they have the access to emergency care and the necessary care for chronic diseases, but all the member states have provided more than that, and including in many countries service tailored to support the specific needs for HIV/AIDS and co-infection. So in the Health Security Committee, we have facilitated the discussion with the European Union member states and the effort to access to high-quality services and in line with the ECDC guidance on migrant screening and vaccination, as well as on infectious disease vulnerabilities of those fleeing from Ukraine. And also the ECDC work on the European Union HIV standards of care is also very pertinent. We had EU-funded the projects to support the modernization and development of a sustainable public health system in Ukraine, and we have created a website for Ukrainians living with HIV, viral hepatitis, tuberculosis, or in need of opioid therapies, and provide the rule of access to care and the treatment options. We have also established a dedicated network on the European Union Health Policy Platform on supporting Ukraine, EU neighbouring member states and Moldova. And this network tries to make it easier for the health stakeholders to share information, to coordinate initiatives, and to prevent the effort overlapping. I would like also to point that the thematic networks 2022 include a network on ensuring continuity of care and quality of life for all people living with HIV/AIDS, viral hepatitis, tuberculosis, and sexually transmitted infections, and has included an adaptive response for all displaced patients. And also, there is a network on anti-discrimination and health equity. The thematic networks are led by the health stakeholders, and they are hosted by the EU Health Policy Platform, as I mentioned. And they will generate joint statements containing actions to be put forward for and by the health stakeholders on this topic. The Commission also acknowledged that the overwhelming response to the COVID-19 pandemic somewhat overshadowed and impacted the access to key HIV and other communicable disease services. And based on the lesson learned, the European Union Health Union Package will strengthen the health security, the prevention, the surveillance and the treatment, as well as the relevant agencies, the ECDC and also the European Medicines Agency. And there will be also, well, there is a pharmaceutical strategy that we are developing and preparing for a proposal of new legislation that will bring the incentives for innovation in this field. There are also financial instruments that are available, such as the EU for Health and the Horizon Europe. For the EU for Health, you know that we have multiplied by 12 the fundings that have been devoted to that for the period of 7 years since the previous third health program. So, and those funds, the EU for Health, the Horizon Europe, could be used to support the strengthening of health system and community response as regard HIV/AIDS, tuberculosis, viral hepatitis, and STI, as well as also effective vaccines, better clinical management options, and the uptake in clinical practice and health systems. We must find effective ways to connect to the key population in order to talk about their health problems and find solutions. And the community services ensure a crucial link to health and well-being of these patients. The Commission is investing over 7.5 million euros under the EU for Health programme on 5 community-based projects that will work to help people who are disproportionately affected by HIV/AIDS, viral hepatitis and tuberculosis to easily access quality services, as well as 3 operating grants that are supporting community organizations working in response to these diseases. For example, just to mention the project Reach Out, with a total budget of 1.3 million euros that will work for 3 years to design and implement an integrated intervention aiming to improve global health outcomes for migrants and disadvantaged local population groups through prevention, early detection and access to care for HIV, viral hepatitis, tuberculosis and STI in 3 European Union countries. Also, the Commission recognized the tangible added value of sharing and scaling good practices for effective intervention, and we are focusing mainly on promoting and speeding up the practical implementation of the action. And we have identified several best practices that the EU member states are working on through the steering group on health promotion, disease prevention and management of non-communicable diseases. The Team Europe is also a responsible global player, and already the European Commission is supporting people that are displaced. We are trying to coordinate the common response. And beyond the crisis, the acute crisis intervention, we have been working on sustainable initiatives to help the world get back on track in the fight against these deadly diseases and strengthen the health systems to better respond to future pandemics and other illnesses. We have been a strong supporter of the Global Fund since it was set up in 2002, and the President Ursula von der Leyen announced a new record 715 million euros from the EU budget to the Global Fund for 2023-2025. And at the fund's replenishment conference. Together with the pledge from EU member states, the Team Europe confirms the strong commitment to the Global Fund with a total contribution of more than 4 billion euros for the period 23-25. and the EU commitment to better health for all will be further demonstrated in the upcoming EU Global Health Strategy that is part of the Global Gateway, which will be launched later, but before the end of the year, in principle. So let me to reassure you that the European Commission has been supporting the Member States and the citizens in fighting the HIV/AIDS epidemic. We'll continue to do so until HIV/AIDS will not longer be a threat to public health, and that we are supporting the whole of the population, not just the residents, not just the citizens, but everybody that is inside the borders of the European Union and also outside the borders of the European Union. Thank you very much.
Many thanks, Isabel, for highlighting what the European Commission is doing beyond pandemic preparedness, because since the start of the pandemic, indeed, the President, Team Europe, as you said, has been working hard on establishing a European Health Union. And it's really important that it goes beyond pandemic preparedness. So I think also the EU Global Health Strategy that you were referring to will be a really important element that I'm sure also this community is looking forward to. So many thanks again. I'm very conscious that you're keen to have a coffee break, so I'm announcing that actually it's going to start now. I'm also very much aware of the fact that I said in my introduction that I wanted to have your contributions, your questions, your interventions, and that we haven't done so. But don't worry, we actually have planned, we had a bit of a side conversation that we do that after the coffee break, because I think this morning's session was very rich in providing you data, background information about what several players are doing. So I'm really looking forward to having indeed your input and your questions after the coffee break. So I just wanted to already flag that. It's now 11:10. I am conscious that our speaker from the World Health Organization is already online. So I really would like to ask you to be back by 11:20, 25 at the latest. So I believe that's long enough to have your coffee, but please be back by 11:25 at the latest. See you then.
Very, very stressful for you, huh? No, usually. I have 8 years. I'm going to wait to hear what you have to say. I'm very excited to hear what you have to say. Just continue the video. Thank you. Yes, no.
We begin with the Zoom session. Est-ce qu'il n'y a pas une sortie qu'on peut mettre directement du PC?
Il n'y a pas de souci, c'est un câble. Regarde les entrées qu'il a. Il n'y a pas de mini.
See you later. C'est ça qui pense à mini jack?
C'est pas un mini jack, hein. Ici, c'est le regard.
Oui, une sortie là, mais qui va vers le mini jack. Comme à la radio.
C'est pas le mini, c'est grand. C'est le jack. Mais il faut un jack, mini jack.
Oui, il n'y a pas peut-être.
Non. Même si j'aurais eu peut-être un mini jack XLR ou un truc comme ça. Mais pas, ça, c'est le jack, c'est pas assez commun. C'est pas les mêmes choses. Même les connectiques, c'est pas les mêmes choses.
On va remettre le micro. Elle va se mettre là.
Non, c'est l'autre. Je ne sais pas. Tu sais, normalement, tous les speakers sont en face. Je ne sais pas comment. On n'a pas. Tu vois tous les speakers. Normalement, ça aurait été bien qu'ils soient en face. Tu vois.
Oh, je crois qu'ils se sont mis.
Oui, mais après. là. Voilà. Non, ça, c'est parce que je ne mange pas. Oui, mais parce que si elle était mal entreposée, elle ne tient pas, même si c'était du racine, c'est le magasin pakistanais. Mais laissez-les là, parce que pour que je les reconnaisse si jamais il y a... Non, mais une autre, elle fonctionne encore. Le problème, c'est autre chose. Quand tu as... Non, putain. Ah, mais c'est... Je vais chercher le 2. Voilà. Tu peux le faire de là-bas. Hein. Alors le 1, il doit être chez elle. Il y en a deux là-bas. Un, deux.
understood this because I told her, and then she's responded this and said I'll drop off at 12, meaning what?
No, she's going to go, so we need to have her presentation done.
The sound from this computer?
The sound is from here.
It's from here, okay.
Can you type in there 3 more minutes? She can't see you, just type 3 more minutes.
So, we're coming on. Okay.
Yes, now I can.
Can you hear me now?
Well, if you mute both, it doesn't help. You have to have at least one unmuted. And now you have 2 channels and both of them are muted.
You see? Hello, can you hear me now?
Yes, now I can.
It depends on your question. But you're next after the break. We're just getting everyone in and you'll be on.
Okay.
Thank you for your patience and apologies.
Can you hear me well?
Yeah, we can hear you well.
Okay, excellent.
Like that, huh?
Yeah, I'm good.
Volume.
Yes, it's okay. Okay, play the video. Where's the microphone?
The thing is now I've muted the laptop because this mic is on, this mic is on.
Yes, when we have both mics, it makes
So when we play the video, we have to mute this.
Yes, this one,
laptop.
yes. Okay. And you can start with.
Great to have you back after the coffee break. Welcome again. Before we go to our next speaker, let me just make a small household remark, because I just understood that I need to urge on you to check out by 12, for those of you that haven't done so. So again, for those of you that haven't done so, please try to ensure to check out by 12. And with that, let me move on to the next speaker from the World Health Organization. I know, Stella, before that you have been with us online, so I'm just looking at our technical support staff to see if Stella still is online and if you also could see her, because that would be wonderful.
Good morning. Can you hear me?
Good morning, Stella. We can indeed now hear and see you, so welcome. It's great to have you with us. You are the principal strategic advisor for infectious diseases at the World Health Organization. I hope that you can hear us well. I don't
yeah,
think...
with a bit of difficulty, I can hear and I understand there is the time for me to make the statement.
Yes.
That is true.
I was just announcing you,
thank
so we're very happy to give you the floor.
You hear me better than I hear the audience. So it is my honor and pleasure to make remarks at this event today on behalf of Dr. Norbert Zulli, the Director of Country Health Program Divisions in the WHO Regional Office for Europe, and welcome you at this important summit. Achieving equity and taking action on refugee and migrant health is a particularly acute challenge in times of multiple crises in the WHO European region's 53 member states. And this is in addition to previous challenges in addressing migration. So some facts and figures. From Sahel to Syria and now Ukraine, we are witnessing large-scale migration and displacement of populations and multiple ongoing humanitarian crises triggered by conflict, natural disasters, and climate change. The WHO European region hosts approximately 36% of the global international migrant population. More than 13% of the people in Europe and Central Asia are migrants themselves. Many countries host multi-million migrant and refugee populations. Germany is the most prominent destination in the WHO European region with nearly 16 million migrants in 2020. Turkey hosted the largest number of refugees and asylum seekers in the world with nearly 4 million. Migration is highly diverse and fluid from year to year. Many countries in Eastern Europe engaged some of the world's largest international labor migration trends and an important migration corridor, having some of the largest immigrant populations in the region. At the same time, many of them have become refugee hosting countries themselves in 2022. In the eastern part of the region, before 2022, key migration flows were between Caucasus, Ukraine, Moldova, Central Asia, Republic countries, and the Russian Federation, and within Central Asian countries. A newer trend in 2022 is a wave of migration from the Russian Federation to the neighboring countries and beyond. In 2022, unfortunately, we saw the fastest growing number of refugees fleeing in Europe since the Second World War, with over 13.5 million refugees that have left Ukraine as of October 2022, and over 7 million recorded across Europe. When it comes to HIV, migrants have a high HIV burden compared to the general population, and I'm sure you have already covered many of these facts and the numbers, and the high rates of post-migration HIV acquisition. Migrants also face challenges in access to health and HIV services, with irregular migrants, foreign-born key populations being more affected. And the evidence supports this. In 2020, 44% of those diagnosed in the European Union and accession countries were migrants with a geographic diversity, but also the highest proportion of late detection, as over 60% in some of the migrant subpopulations being in advanced HIV disease. So substantial gaps in data exist on HIV burden and access to the HIV continuum of care, particularly for individuals in the precarious circumstances and irregular status. In the eastern part of the region, the migration and HIV is less well evidenced as systematically captured through routine and non-routine surveillance. Now, since 2016, WHO Europe has implemented action plans that also included actions to deliver effective services for treating TB, HIV, and viral hepatitis. And these were the plans that were designed in 2016, 17 to 2021. One of the examples of implementation of the plans was developing the WHO Essential Package of HIV services in migrants in Central Asia, with 5 major components that included actions around commitment and stewardship, legal aspects and ethics, finance, service delivery, surveillance, and monitoring. So where we are right now, at the international level, what needs to be done has been well defined, and we heard from the previous speakers. In 2021, WHO Europe released the report of Health Evidence Network. What is the evidence of existing national policies and guidelines for delivering effective tuberculosis, HIV, and viral hepatitis services for refugees and migrants among member states in the WHO European region? The goal of this was to see how international recommendations on effective services to treat these diseases for refugees and migrants have translated into the national policies. But the report found that only 15 policies and guidelines on TB, HIV, and viral hepatitis services for refugees and migrants were identified in the 53 member states. Often, these policies and guidelines do not align with WHO and European Center for Disease Control recommendations. Implementation also varied widely among member states across the region, and international recommendations lacked implementation across the region. So some examples, both ECDC and WHO strongly advise against mandatory testing of migrants, but we still have 2 countries out of the 19 worldwide that deport and deny residency for HIV positive non-nationals who otherwise remain undocumented migrants. Many countries remove travel restriction, but some countries still impose this restriction or request HIV testing or disclosure for certain types of entry, work, study, or residency permits. Free access to screening or treatment for TB, HIV, and viral hepatitis B and C varies considerably between the countries and really depends on the disease. And even if free access to health care is available to migrants, systemic barriers were identified. Now, in 2022, the WHO European Office has developed the regional action plans for ending AIDS and the epidemics of viral hepatitis, sexually transmitted infections. And these outline the vision, goals, and actions required to respond to these epidemics. Migrants are listed among key and vulnerable populations across the 3 core areas of response. So, addressing effectively HIV as well as other communicable diseases remains unfinished business. It is time for a new narrative on refugee and migrant health that builds upon what we've already done and takes us to the next level, including a recognition of the important contribution that migrants make to our societies. There are some clear priorities at the country level. First of all, alignment of national policies to international recommendations and especially their implementation. Strengthening routine health data collection to improve monitoring of migrant health data and optimize targeted screening strategies and integrating migration health data into national health information systems. Ensuring equitable access to general health and HIV service will help us to implement interventions to reduce stigma and discrimination, which are crucial to ending AIDS by 2030. Addressing stigma associated with a diagnosis of TB, HIV is frequently highlighted as a barrier by migrants. They may experience fear and lack of trust, particularly about their right to remain in the host country, and may have limited knowledge of the local health and social care services. At supranational level, we see cross-border collaboration and clinical data exchange as key to changing the paradigm how we address HIV in migrants. This remains essential to a robust and people-centered public health response. The refugee crisis related to the war in Ukraine has shown clearly the gaps and the acute needs. Together with partners, with the ECDC, with UNAIDS, with civil society, with clinicians across member states and many other partners, we've made significant joint efforts to address the regional collaboration to ensure access to HIV service among refugees fleeing from the war in Ukraine. Yet, due to the current data system limitation, the routine clinical data exchange mechanisms do not allow for regular feedback for refugee hosting countries to the HIV program in Ukraine to have a clear picture of how many people have been linked to care or are on treatment as we speak, not in a year from now when countries report. So So we really need stronger cross-border approaches that are focused on much more effective and agile data sharing systems across countries in all parts, east, center, west, but also across the region. So I'd like to close with a quote from our regional director, Dr. Hans Kluge. Regardless of the myriad factors that propel migration, it is not a modern or distinct phenomenon, but an enduring, enriching, and vital part of our society, an essential ingredient in how we as communities and people thrive. So these remarks made at the high-level meeting hosted in Turkey in Istanbul in March this year to craft a joint new vision addressing the health and well-being of refugees and migrants as well as host communities, considering both current realities and anticipating future opportunities and challenges. And this has been convened by WHO Regional Office for Europe with support with WHO Regional Office for Africa and Eastern Mediterranean, encompassing 122 countries and territories. So changing the narrative to achieve this vision needs also backup with sustained programmatic efforts and investments into supranational collaboration. Only together, the agencies and partners, the member states, the communities, we can achieve this. Thank you.
Well, many thanks, Stella, to have this contribution on behalf of the World Health Organization. I was very much struck by what you said about reaching target remaining unfinished business. And also well defined, so action is needed. So with that, again, thank you very much for being with us, for representing the World Health Organization. And I think that is a really good bridge to the interventions that we're going to get now. Because we need to focus on the national perspective, because after all, healthcare systems are very national in form and shape. So I'm very happy indeed to have now our next two speakers, starting with Gonzalo, followed by Luciano, really that bring in that more national dimension. Luciano, Gonzalo, let me start by you, not mixing up speakers. You are an expert in your field. You're currently the Vice President for Regional Relations at the International Association of Providers of AIDS Care. And you're going to speak to us about the need for migrant-sensitive responses.
Just trying to find my presentation here. Just give me two. Thank you so much. So, oh, that's cloud note. Good morning, everyone. My name is Gonzalo. I'm the P for Regional Relations at. Should I switch mics?
Yes.
Yeah, thank you. And next slides, please. So I'm going to zoom in a little bit on the migrant MSM situation in the EU, and also try to shed some light on way forward in terms of the intervention with migrants. Just a little bit of recap. So as you can see, we do know from the Eurostat's numbers, the top 10 nationalities of first residence permits for 2020 and 2021. And in there you can see that, of course, Ukraine nowadays has risen a lot in terms of appliance to permits in the EU. It's the first column. And then you can see also countries from Eastern Europe as well, as from Belarus and Russia as well. And then on the last one, and also pointing to what we have discussed in terms of the importance yeah, back again. Yeah, so Do you think so? Yeah, okay, got it.
Last time. No. Then I think there's a problem with the frequent. I will ask what.
Like this? Alistair? Really? Yeah, I know you're the showman, so. Everyone can hear me if I.
It's just for the speakers online.
Oh, sorry. Yeah, the speakers online. Yeah, but isn't it? I got the one here. Okay, just pointing out that the last column, of course, is the United States, and they don't refer them as to migrants. They refer them to as expats, and this is a nuance that we all should keep in mind. So, migration, expats, and nowadays also the digital nomads. So we are also seeing a shift in terms of the intervention of our focus, not only relying on migrants, of course, but there are inequities and vulnerabilities to it. When we look into the other graph, then we have the first-time asylum. You can see that most of the countries are from Northern Africa and also from the Africa diaspora. Next slide, please. As Timur already pointed out, and you will see the same graph, migrant MSM are the only group where we saw an increase over the time of 30% in terms of new HIV diagnosis. So that's the Do you want me to swap places?
I think there's a problem with it.
Oh, okay. Yeah, so as I was mentioning, that's the blue dotted line, and there you can see an increase of 30% over time. And ECDC has highlighted this before, so in previous reports we do see the importance of migrant-sensitive services and also the upscaling of these interventions, giving the increase specifically on migrant MSM. And we do know from the UNAIDS 2022 report, the Global AIDS Update, that MSM worldwide are 28 times, have a 20 times 8 higher risk of acquiring HIV. Next slide, please. So what did we do? We did a literature research, and this October 17 was the second round of it. We did a research in PubMed, and the search criteria was to look out for papers that specifically target migrants and MSM for the past 5 years. We found 69 articles of it on PubMed, and of those, 63 were excluded. And our exclusion criteria were that they didn't refer to the EU or the European Economical Area. So of the 69, 30 were excluded due to that, and then 32% were excluded because they only addressed migrants or MSM, and then don't combine both categories. And that seems to be an issue overall, not only in terms of the epidemiological data, but also in terms of research. So we are not capable of actually capturing the essence of migrant MSM. And then lastly, one was also excluded because it didn't address neither MSM nor migrants. So we ended up with 6 articles out of 69. Next slide, please. So, and I believe I don't bring you any news because you're all in the field and you all know what we are talking about. So we do see that structural stigma is influenced by precautionary behaviors among MSM migrants. And I would like to highlight also, again, language is important. In some research, we do see that authors address MSM migrants, and then in others we see they address migrant MSM, and that's one of the dilemmas that I think we are also facing. So, first dilemma. Then a further research we saw that also that migrants MSM were more likely to be undiagnosed, so 10 percentage points when compared to local MSM, and then also experience greater loss in terms of the retention in care, in terms of virally suppressed, and also on combined antiviral treatment. Also highlighted was that they are more likely to have experienced a HIV discrimination, especially in healthcare facilities. So that has been brought up by our colleagues from the Netherlands. And then lastly, Norwegian-born MSM had the lowest estimated number of undiagnosed infections when compared to migrant MSM Norwegian-born heterosexuals. So again, when we zoom in and look at specific populations, even there we see that migrant MSM have poorer outcomes when compared to other groups. And being on the topic of Norwegian, one of the things that I would highlight is that Norwegian actually has a law in place that everyone that sets foot in Norwegian is entitled to HIV treatment, regardless of their documental status or being legal or illegal. Portugal, from where I come from, and unfortunately my countryman MP is not able to join us today, talking so much about the political commitment, but I will address this with him, rest assured. Portugal has actually released a policy 4 days ago where, similar to the Netherlands, entitles people to have a working visa for 6 months just to seek work for 6 months. But again, we do need to address after the 6 months what happened and if they are entitled to social security. Next slide, please. So talking about a little bit about the dilemmas. So we do see documentation dilemmas. So we try to work in silos, meaning migrants, MSM, sex workers, etc. But then we don't actually, or we aren't able to capture the intersectionality of all the dynamics that are happening with us, actually. Then, and rest assured that the dilemma is faced by all customers targeted services. So that happens in IT, that happens in online services. This is not exclusive for healthcare. Then about the segmentation versus expansion. So if we expand our criteria, are we going to capture what we actually need to tackle? Then, of course, one of the dilemmas that was also mentioned here is establishing the data set. So we are working within I would say not too robust data set, and we need to readjust and monitor and learn and again adjust it accordingly. Then what comes first dilemma that I already alluded to, so we see in some literature that we have migrants, in others we have MSM, in some of them, and we know also from research that some MSM refer themselves first as migrants and then as MSM, and then we have others that are more willing to seek the responses that are MSM specific and not migrant specific. So how do we integrate both realities into one? And then of course also the dilemma between native and migrants. So from a legal point of view, we have plenty of people that are second or third generation migrants, but they do refer themselves as still being from the original countries, from their parents, their grandparents, etc. And then the whole subject about intersectionality that I already mentioned. And then one last thing is are all migrant MSM also openly about it? So meaning we know we will never capture, due to certain circumstances, all migrant MSM that we want to target. Next slide, please. So possible ways forward. So bear with me, this is work in process. What we thought internally in terms of our team and jointly also with Gary Jones here from UNAIDS is that of the laws of each country on migration and access to healthcare per country, and at the regional level when applicable. So it was already mentioned here, Andalusia has a law that entitles people to have access to treatment regardless of their mental status, and also not even having an address. But we do need to, and at least to our knowledge, that hasn't been done on the EU level, we don't know per country what are the laws, not only in terms of migration, but also in terms of refugees, asylum seekers, etc. Then putting on my, not that I belong to that group, but putting that cap on in terms of white supremacy, heterosexual men, we thought that they would like to know in terms of health economics how much it actually to healthcare, and also on the other end, what's the contribution of migrants to the welfare and economical systems of each countries. And we do have already data on this, so it's easy to retract. And then also, of course, one of the things that we most likely are going to be confronted is the criminality rate, migrants versus native. So this is something that we need to highlight, since there are already studies, and we can easily refer the primacy of migrants not contributing to social and welfare systems and not being proactively involved in societies of the welcoming countries. Next slide, please. Then, keeping in mind that we would like to put a policy paper forward to the EU, we would like to have a group of experts that would convene to actually discuss the current status of access to healthcare by migrant populations, refugees, asylum seekers, and displaced people. Present them with the outcomes of the literature review and what should be the next steps for countries. And again here, not only on the country level, but also at the region, canton level, and then also on the city level. And especially important, determine the baseline assessment and which variables should be monitored over time. Lucia, albeit having this law, they don't really have data right now in terms of has contributed to the overall economical increase in Andalusia, given that migrants, given the migrant influx and the impact of this law. And then the actual policy paper based on the previous three items, so the literature research, the map of the laws, and then also the inputs from the group of experts. Next slide. Then, of course, as mentioned also here, every intervention should be action-oriented. That means we would like also to host a regional migrant-specific of the policy paper, and of that then also hopefully establish partnerships. What we have been working with at the Fast Track Cities network is to establish two networks of Fast Track Cities. One Lusophone, meaning all the Portuguese-speaking countries, and another one of the Hispanic network, meaning all Spanish-speaking countries. And we have the collaboration of the Ministry of Health of both countries, because we do think that's the way forward. And then, of course, measure the impact. How many countries, regions have implemented the recommendations, of how many partnerships were officialized, and what is the impact compared with the baseline assessment. Next slide. So, and this is actually just to finish, what are we missing? And this is also from a research level. So we don't have research that covers and captures the multi-level, the multi-dimensional, and multi-directional of migration. And poorly, it's not too action-oriented. Being cautious of time, I believe that's it. Thank you.
Well, many thanks, Gonzalo. I think that was excellent. But the data that you provided, the possible ways forward, I think this was exactly what we needed. And I'm sure that building on yesterday's discussions, a few of the dilemmas that you presented may lead to questions or interventions from your side. So I'm looking around because we have a few minutes for questions or intervention. So without wanting to put anyone on the spot, can I see anyone wanting to speak? Yes, I see a hand up. Yes, you have the floor, please.
I just really wanted to thank you for your presentation, Gonzalo, and also your mention of the Pachankas data, and because I think it's not mentioned often, and I think it's really important data, and it reflects back to what we were talking about yesterday, about sometimes the inability of our own organizations and our own communities to respond to migrants. And I wanted just to highlight the one point that he's talking about intra-community stress, and he's documented a lot of stress between and among gay men and men who have sex with men inside their own communities, so that there are tensions between older, younger, migrant, non-migrant, based on race, based on looks, based on body images and all of that. And it's very rarely documented. So it's great that you're including it. Thanks.
Thanks for that intervention. Anyone else? Just, I think, I see a quick point, look at it, you wanted to make. Yes?
Thank you very much. I think one of the points you were making was extremely important for the discussions we're having about migrant MSM or MSM migrant. And I think when we are talking about lack of data, that was also really visible in Tamir's presentation. Sorry, I'm Luca, I work with the European Sex Worker Rights Alliance. And this is something that is for us extremely important as well. We know that the majority of people who sell sex in Europe are migrants, many of them undocumented, many of them transgender, MSM, also maybe using drugs, etc. And I think for us, the key issue is that without the right information about the HIV prevalence among sex workers, we are not able to develop rights program and right policies. But the issue is that there is a huge political backlash against sex workers' rights at the European level. We see many countries criminalizing sex work, criminalizing clients, in particular Sweden, France, Norway, Ireland, etc. And I feel like we often have this really feeling of hypocrisy where on some hand you will have the city of Paris being like a fast-track city, but at the same time seeing clients of sex workers being criminalized. And we heard yesterday from Kim, from PAST, the local trans migrant sex worker organization, that HIV rates are going higher in specific communities, in particular trans, MSM, sex workers. So I think one of our main recommendations is that we talked earlier about what we need is political will, but political will is not detached from our communities. We are the one who can push for this political will to change. And just to take you one example, currently in France, there is 261 sex workers, the majority of them migrants, some of them male sex workers as well, who are taking the French government to court, to the European Court of Human Rights, for infringement of their right to health, in particular, because we know that the criminalization of sex work has a hugely negative impact on sex workers, and in particular migrants, MSM, and trans sex workers. So I think when we talk about political will, it's also to remind ourselves, at this event in particular, that we are the one who can push for this change and really supporting community-led initiative, including strategic litigation, including programs led by the community. Thank you very much.
Well, many thanks for these interventions. I believe indeed pushing bottom up from a community perspective is very important indeed to create that political will that we need. Our next speaker is Professor Jeffrey Lazarus. I hope that he also will be visible for us because Professor Lazarus brings a wealth of experience. He has a decade-long career working on healthcare systems, HIV, currently is at the IS Global and University of Barcelona. He's the head of the Health Systems Research Group there. And I believe he would like to start with a video. So I'm looking at our technical experts if we could see him. And indeed then at some point start with the video.
Yes, please start with the video. You're able to hear me.
Yes, we hear you. We hear you well, Professor Lazarus, and we're just trying in here in a room in Brussels to get your video up. I love the best of every just coming up all the time. Well, I think that was a very telling way of setting the scene, Professor Lazarus, especially given you're going to focus on the global consensus of ending COVID-19 as a public health threat. And I think from what you just showed us, it's very clear that indeed COVID-19 is still very much a health threat and only again aggravates the current health inequalities that we're seeing. So here in the room, we're now trying to get you up because we heard you, but we haven't seen you yet. So let us perhaps give a few seconds to make that happen as well.
Okay, it's a little hard to hear you. It's a little hard to hear you, but you said you can't see me yet, is that right?
Yes, we can't see you yet, and I also heard that you have problems hearing us, so we're trying to solve both issues.
I can hear you, just not terrific.
We're just getting up your slides. Yes.
Okay, there. I can share my slides.
Okay, that would be really good.
Great. I hear you perfectly.
Let's make it focus and then you can share.
Yes, Professor Lazarus, we now see you very well, and I hope that you still hear us well too. And we also have your slides in front of us.
Are you able to see the slides?
Yes, we are. We do see them, and we also hear you very well.
Great. So they should be at the start now, and you'll let me know if they don't advance, because sometimes they do on the screen. Well, thank you very much for the invitation to join the Mind the Gap meeting. I'm sorry I'm not there in person. I'm in Washington, D.C., and I'm going to be launching in just about 5 hours this global effort called a multinational Delphi consensus to end the COVID-19 public health threat. And I realized that the Mind the Gap meeting has a much narrower focus on migration issues and HIV and related issues, but I appreciate the opportunity because everyone now has lived experience with COVID-19, and it has been particularly challenging for people living with HIV, for many of the migrant populations, really for everyone. And I thought this was a unique opportunity, since we're going to launch soon, to share this with you. So this study had more than 40 core group members from 25 countries. It started about 15 months ago when I had an idea to write down the relevant recommendations, because there were so many at the time. And I asked other specialists if they could recommend the key recommendations in their area. And it snowballed and eventually became 386 panelists from 112 countries, as I'll show you in a moment. I think we're all familiar with the background. We are still in this pandemic, and despite notable scientific and medical advances, broader political, socioeconomic, and behavioral factors continue to undercut the response to the COVID-19 pandemic. Highly transmissible variants continue to spread globally, while surveillance for variants of concern remain largely inadequate. Reinfection risks are not fully understood. Low vaccination rates may compound the risk from waning immunity, and long COVID has emerged as a serious chronic condition that represents a considerable burden of disease and still lacks adequate understanding and appropriate preventive or curative solutions. So with this in mind, we embarked on a Delphi process, a 6-step, 3-survey process in which we refine statements and recommendations, and as you can see on the far right, ultimately agreed on 41 statements with a high level of consensus and 57 recommendations. I'll go through some of them briefly, divided into 6 domains. If you read the small print, you'll see that during the process we had over 5,000 written comments received from the panelists in addition to the voting process. So it's a very rigorous methodology to reach consensus and ultimately achieve an outcome of recommendations that have teeth, that are actionable, that are important, but also have a high level of consensus. One of the big goals was to ensure that this was a global effort, which has been, as we know, one of the big failings of the pandemic response. So here we are from 112 countries and territories. It was difficult to find people from some countries. We had a reasonable gender balance. We had a reasonable low and middle income and high income balance, as you see on the right, 51 and 48%. And also in the right under characteristics, you see that all parts of the world were represented. There were a number of panelists, particularly from low and middle income countries. We wanted to make sure that their voice would be heard. Now, with 57 recommendations, we were told it would be helpful to present the top half of them. And here you see them by domain: health systems, prevention, communication, pandemic inequities, treatment and care, and vaccination were the main domains we focused on. There's overlap, there are other issues recommended and discussed, but this is how we divided the work. And here, and I won't go through them all now, you see the top half of the recommendations presented, and here you see the top 10 by domain. Really the top 3 recommendations that came out were a whole of society approach, a whole of government approach, and a vaccines plus approach. And you might say, well, we know all of that. But what was important was that we also demonstrated it, the whole of society approach, by involving not just public health experts and infectious disease specialists, virologists, epidemiologists, but also a philosopher, an anthropologist, a lawyer, many community representatives, people living with HIV, many people who have been migrating and define themselves as migrants, in order to have that whole of society approach that's been lacking. The whole of government approach, where we see the response very siloed, even when it's recognized as being more than a health issue. Often the different parts of the government are not collaborating in their response. And finally, the vaccines plus approach that was launched in January in the BMJ of this year by a large group. We again found a high level of consensus that we need more than vaccinations to get out of the pandemic. That includes prevention measures like improved ventilation, like using face masks in crowded, poorly ventilated indoor areas, but also economic and other incentives and measures to help those who are most vulnerable and marginalized get the care and prevention measures that they need. So the whole of society approach specifically called for pandemic preparedness and response planning should adopt a whole of society approach that includes multiple disciplines, sectors, and actors. And all countries should adopt the vaccine plus approach that includes a combination, as I mentioned, of vaccination, other prevention measures, treatment, and where needed, financial incentives. And finally, we have a statement and a recommendation that face masks do work amid all of the controversy about what's working and not working. We worked with the experts who stated very clearly that we need multiple social measures and structural interventions, and that includes remote working, schooling policies, ventilation, air filtration, and face masking with high quality face masks in public transportation and indoor settings. And for those populations that aren't able to afford it, we need to provide those free of charge. We had recommendations that were also sometimes more relevant or at least equally relevant in low and middle income country contexts. I won't go through them all now, but this is not an idealistic, aspirational plan or strategy or set of recommendations to end the pandemic as a public health threat. It's something that we believe is realistic if the world shows real solidarity, the kind of solidarity that was expressed with CEPI, with the COVAX facility, with other initiatives, but we've seen far too often failing. That means we need to address pre-existing social and health inequities, very challenging for governments, that we need to have better pandemic preparedness, and we need to have a stronger response now, including for those in conflict zones. That was a recommendation driven by the current conflict in Ukraine, and that high-income countries should refocus the distribution of vaccines to countries with low rates of vaccination and inadequate access to vaccines. The situation has since been improving, but we know that it is not adequate to prevent severe symptoms and hospitalization in all who need vaccines right now. So I'm going to stop there. I just wanted to share this global effort and also highlight that one of the successes, I think, of this article ultimately is that it really was a global collaboration that heavily involved community-based organizations. We've had an endorsement process, and many of the organizations I know in the room, including AAF, and the Nobody Left Outside Initiative, HIV Outcomes, and others, have endorsed the statement, which we think is quite exciting, quite unique, because the story doesn't stop when this goes live in 5 hours. It continues when we work with and have this bottom-up push with our governments and with our health authorities to implement the recommendations we need as we here in Europe enter the winter season, and we know cases, people with severe symptoms and hospitalizations and deaths are inching up. Thank you very much again for the opportunity to present, and I'd just like to also acknowledge everyone who worked so hard on this for over a year, the team at IS Global, the team at the City University of New York School of Public Health and Health Policy, but really the core group of authors and the almost 400 panelists that have been involved and taken so much time to respond to the voting and to provide their comments. Thank you again for the opportunity.
Well, many thanks to you, Professor Lazarus, for your very timely intervention. I think it couldn't be more timelier with the 5 hours publication time, indeed, for the article that so many of you worked on together. So many thanks for being with us, and we hope to stay in touch as a community.
Great, thank you.
We have been awaiting our next speaker for quite some time, so I'm very happy to now announce Luciano Nigro, Dr. Luciano Nigro, who works as an infectious disease specialist in Zimbabwe, if I'm mistaken. And we're very happy to have you with us the whole day already, and we're very much looking forward to your intervention. I believe you're getting a mic. Thank you.
Good morning, everybody. Thank you. I think it had been better to have my presentation yesterday because what I'm going to say is really linked to what we said yesterday. I'm going to speak, but really briefly, about inequalities. Yesterday, we spoke a lot about inequalities, and if we need to understand if we have to scaling up service for migrants, this is the first inequalities, because it means that we don't have the same services for migrants than the service for the general population. Yesterday, we had the opportunity to share lots of impression, emotion, and Jackie was very clever to summarize the plan for the future and to dream about our future. No? To speak about inequalities, we need to go back to the field, to what happened in the field. So I would go to explain what we do in Catania. I'm here Representative Live Rights and Prevention is a small local association, volunteer association in Catania. Am I going to go? No. Was founded in 1991. It is 30 years that we work, and we promote and defend the universal right to health, organize campaigns to reduce the spread of sexual transmitted infection. We are committed in affirming principles and relationship of solidarity, and we fight against all form of violation of human rights of people living with HIV infection or suffering from AIDS, and all vulnerable groups like young people, women, sex workers, drug abusers, prison population, and migrants, by building human and social integration service too. Next. The association is composed by volunteer, member, and operators who express the following professionalism: live operators, peer operators, social workers, psychologists, cultural mediators, doctors, teachers, and free citizens. Our intervention strategy is the harm reduction strategy that is implemented through the offer of low threshold services. Okay, I'm going to repeat some of what we said yesterday. As WHO stated, as for all people, refugees and migrants have a fundamental right to enjoy the highest attainable standard of health, addressing the impacts of migration and displacement on each person's physical and mental well-being, and advocating for the diverse and unique needs of refugees and migrants is therefore a priority. Addressing their health needs is instrumental in facilitating integration and participation, stimulating positive social and economic development, and bridging development and public health issues. Next. Health promotion helps to support people to control and improve their own health and well-being, and to interact effectively with the healthcare services. Starting with this concept, we tried to plan a program, and we submitted this program to UNHCR. Okay, go on, please. Go on. Refugees and migrants need to be in good health to protect both themselves and the host population. They have the human right to health, and countries have an obligation to provide refugee and migrant-sensitive healthcare services. We go on. And so we plan this pro-access program, improve access to sexual and reproductive health services for refugees and asylum seekers that are survivors of GBV, gender-based violence, and M and FGM, are the mutilation that are for male and female. So we planned this program in 2018. We proposed to UNHCR, and they are our partner up to now. We are still running this program. Next. The activities are implemented by a multidisciplinary team: doctor, psychologist, social worker, cultural mediators, a coordinator, and are supported by volunteer, life staff, and life qualified doctors. The team includes 2 live problem-solving supervisors, one for ongoing technical matters and the other for medical issues, and carry out a fortnightly supervision led by a psychologist of the public health system, to try to avoid problems in the group, but also to try to avoid problems in the cultural mediator involved in the program. Go on. Some of the activities, the most important, are outreach activities, informative sessions, live drop-in center activities, and training activities. The outreach activities are mainly run by cultural mediator, together with live volunteers. Go on, please. We map continuously the community to individuate the place where the migrants, they stay together. Are not only offices like the lawyer offices, they need for the document for problems, or the health service of the public health system, but also the mosque or place where they stay together. And we go to do outreach on the street for the informal migrants and in these places. And in these places also we offer the HIV test, hepatitis C test, and pregnancy test. The other important activities of the outreach cultural mediator is the accompaniment to the offices they need for their needs when they don't speak the language very well. The informative session, we have 3 sessions. One is related with the health problems, related with the reproductive and sexual health. So we explain them when they have to look for a doctor. So we speak about symptoms. But the second session is the most important because we explain them, and it depends of the setting. You know, the setting can be the street, can be the informal places where they meet, can be the reception centers. So in the reception centers we have the educators, psychologists, so the information is also for them. How to recognize mental problems, you know? This person doesn't sleep, doesn't have attention at school, is not able to eat properly, no? And when they recognize these symptoms, to send to the proper service. But at the moment, the proper service is the live drop-in, where they find all the specialization they need. So the third session is to offer the testing with pre-counseling, that can be group counseling or individual counseling, and the post-test counseling that is always individuals. It depends on the setting. The informative session can be for 3 days. So when we go to the reception centers, it's very important to do a very exhaustive session. If we are on the street, usually we try to send them to the drop-in center, but of course the informative is shorter, and we don't like to do that, but can be 1 day, 2 days, or 3 days. It depends on the setting where we are, and can be individual or group. What we do at the drop-in, we open to people of consent a week, offering friendly, low-threshold access. It means they come when they want. They don't need to book. This is very important because in this situation with vulnerable people group, if you, the first barrier is to book. Today I want to go, tomorrow I have other things to do. Activities in the drop-in include medical consultation, individual and group psychological support, and therapy. This is very important because we started with support, and with time, now we are able to offer a special set for migrants because, you know, the psychologists, they want a specific setting, 6 months, whatever, so we have a very low threshold proposal of therapy. This is mainly for women, but for us, the violence is for everybody. It's for men, for young, for women. So we offer this at the moment, the therapy. 2, social service and legal service. We propose HIV and hepatitis C test and pregnancy test. Why only HIV and hepatitis C and not hepatitis B? Because at the moment we do the salivary test. We don't have salivary test for hepatitis B. It's just with blood. We are trying to organize this. Training activities. This is a very important activities for the program. We train all the staff of the reception centers, the NGOs, local NGOs, cultural mediators, public and private health operators, students, and live volunteers. We have an agreement with this program with the local authority, health authority. So we train their staff on harm reduction strategy, sexual transmitted infection, prostitution, substance use and abuse, because it's different, migration, focusing how to welcome and to deal with migrants. And to explain the importance of the cultural mediator. We have cultural mediator in the psychological treatment, therapy, that is very difficult because for these people, when the person speak about their problems, are the same problems of the cultural mediator. So it's important to support them with the psychologist too. Go on. So the main result, in 5 years, we have reached about 2,000 migrants on the road and whatever. We performed about 2,000 HIV tests and 1,000 hepatitis C tests. We got around 12 or 13 HIV positive person and about 15 hepatitis C person. All of them, the hepatitis C, they were already treated because we act, I forgot to tell, we act as a bridge to the public services, So they were treated, and only 2 of the HIV positive are not yet on treatment because they are refusing the treatment. So we are working with those. We have, we have carried out about 1,000 accompaniments to the services. Okay. Okay, what we learn from our work? Where are the inequalities? This is the first, the documents. Imagine us just one day without documents. It's impossible for us. The lack of documents blocking certainly slowing down the realization of one's life project over time, overshadows every other goal, including the right to health and to work. In this sentence, we have 3 inequalities there. Go on. It is important to reach migrants as soon as they arrive. Migrants, especially minors, are still confident and ready to be assisted and guided. When they have been in our territory for years, they have lost all confidence, both towards the host institution and the operators. Importance of low threshold services. This is something that is specific for vulnerable groups. All operators subjected to violence during all migrants are subjected to violence during the journey to reach European countries. Violence is always psychological, often physical. Just think that the journey, which normally lasts more than 2 days, for some of them lasts from 6 months to years. I met a Somali young man. He started the journey when he was 14. He arrived to Catania when he was 21. You know, this is, without violence, is a big violence. Where is the adolescence of these people? Many migrants leave the country as teenagers, yes, I told. The problem violence must always be evaluated and faced if a fruitful involvement of migrants in integration processes is to be achieved. Sometimes we don't have this holistic approach. Another important gap is the language, both intended as a means of communicating and as a means of disseminating cultures. This is very important. The role of cultural mediators is pivotal, basic and essential. They also hold the role of peer operators, and we know that peer operators programs are the best. Lack of information. This is another inequality. They don't have information about the laws in force and about their rights. For example, in Italy, the health system is free for them, with document and without document. With document, they can access to the health service, they can access to the general practitioner, and without document, they are entitled to get emergency all the children they need, the women, the health of the women, infectious disease, vaccination, and chronic disease, but they don't know. So the importance of association in this case, we are not even in a very good future. We are essential because we are flexible in our way to work. The public service is not so flexible. So the association has to, those who are giving information. Next, I'm going to finish. It is necessary to be able to have a clear dialogue with the law enforcement. This is a very strong inequalities. When they speak with me, they speak in a certain way. When they have a migrant, they are different. Just the lack of training, I told already, and the lack of funds, we said already. But this is, for me, the main inequalities. The application of the article number 13 of the Universal Declaration of Human Rights that was written in 1948. Everyone has the right to freedom of movement and residence within the borders of each state. Everyone has the right to live in any country, including his own, and to return to his country. It is the fundamental right to inhabit the earth as common home of all members of the human family. Freedom of movement is an indispensable condition for the free development of the person. And this is the main inequalities between migrants and migrant people. Thank you very much.
Well, thanks to you, Luciano. That's a very powerful way of ending a presentation, I'd say. And many thanks also for sharing your impressions from the ground for what you're doing in Catania and also the need to scale up interventions. And I'm sure that you, having listened to Luciano, may have some reactions or some questions that you would like to bring to the table. Yes, please.
Thank you so much for the wonderful presentation. I have two questions. I mean, some 9 years ago, I landed in Sicily by dinghy boat from Libya, which took me 10 to 11 months from the Gambia. So as I learned, or as we all know, Catania is a destination to many people from sub-Saharan African, refugees crossing from sub-Saharan Africa. I mean, on the presentation, you haven't mentioned any countries. Maybe could you explain what are the destination, countries of origin of these refugees? And also you have mentioned about psychological support. I mean, how were you able to manage psychological support for these people? I mean, what methods do you use? I mean, because these people are different, completely from different regions. Thank you.
We try to work always on the issue of psychological support with the public services. So we have always psychologists and psychiatric from the public who does our supervision and help us when we need treatment, because sometimes treatment is not necessary. This is the problem we are living now in Sicily, because most of the people that are coming by sea, they don't want to stay in Italy. They want to reach, they want to have their plan is to reach and to join the families, the parents, the relatives they have in Europe. But without documents, they can't. At the beginning, they don't understand this, but when they understand that they are in jail, because it is like to be in jail on the road, on the whatever they stay, because they can't do nothing. They want to go. So it's difficult to work with them after 2 or 3 years, because they don't trust you. And this is a problem. And they don't go to school, even if the school is basic. The education, they don't care about education. They don't care about health. They care about documents. So my advising, when you work with migrants, first try to address the problem of the document.
And the countries of origin, like
No, we have everywhere, yes. But mainly from Costa d'Avorio, Ivory Coast, Nigeria, Senegal, but we have from everywhere. Not from Zimbabwe.
Did I see another hand up? I'm looking around. Anyone else? Yes, I think to my left.
Hola, hey. I'm Oscar. From Sweden. I'm listening to you, what you say about so important when the immigrations arrive to Europe, they come in from the sea. They come from the sea without papers, without license. They illegal. That's what we said yesterday. Important to contact them in this beginning, because this is the door to Europe, and there's a big door in Canary Islands, is where I come from. I'm the little baby of this institution. I'm learning, so I think it's important to contact them in this moment, and I don't know if they're really doing something. So if I can have ideas, or someone can tell me what we can do, I think this is a very important.
What has been done in Italy with the last government, no, the two last and this one, is to reduce the reception centers. So at the disembarkment, what they do, the police, what they do, they have a number of places, they fill the places, and after they turn their shoulder and they leave the people to go on the street. So when they go to the reception center, our program now has the contact. They call us when they have new arrival. So we go to, but on the road, what do we do? Some people, for example, people coming from Eritrea, they have some already done road to go directly to Europe. So they leave immediately Catania. Some others too, but most of them, they stay on the road without job, without welcoming, without support. And that is very, very difficult because the police doesn't help us.
I know, that's happening the same in Canary Islands. Yeah. They are arriving massive people. And sometimes government institutions, they hiding all this from the people, from local people. But things, we should do something too.
We need to vote.
They put them
different
they put them in the centers, apartments, hotels, and I think this is important point to get them in contact with them. Thank you.
The lady.
I see more questions. I'm just conscious of time, and we still need also a speaker with a very interesting contribution. So what I propose is that we go to our next speaker, and then we have some time for Q&A. So please keep your questions and keep them, for 10 minutes or so. So with that, Magdalena, I'm looking, you're at the end of the table now. So we're going to our next speaker, Magdalena Ankerstein-Bartschak, if I pronounce that correctly. Magdalena, you're a very well-recognized HIV activist and currently president of the Foundation for Social Education, Social Education. And we're very much looking forward to your contribution about how Poland has been dealing with supporting Ukrainian migrants. So I hope you got your slides up and running.
It's coming. But because we are also running on time, so thank you very much for invitation. It was last call for me, so I will try to speak briefly. My name is Magdalena Ankerstein-Bartschak. I'm PhD of sociology, working 20 years on the Foundation of Social Education. It's organization dedicated mainly for sexual and reproductive health, but also I'm mainly working around STI, HIV, and hepatitis. I'm a member of ECDC and also working in international cooperation with many organizations. So also it was one of the reasons why when the war was starting in 24th of February, most people from Europe asked me about what we are doing and how we are faced on the new situation in Poland, because of course for many years we had the Ukrainian people in Poland, but there were many workers, and so we were familiar. Yeah, great. We were familiar with Ukrainian, but most of them are going back to their country to care and healthcare system. But of course, after 24th of February, the situation was changed. And what it is also, when we are talking about HIV, what was mentioned by Timur before, the differences between epidemic from West and East Europe, and especially we knew about it that 47% of people linked with HIV in Ukraine are women, and most of these women coming to Poland with kids. You have to also know about the situation in Poland, that it's not very good in the European level. We have very high number of undiagnosed people, and as you can see on this slide, it's quite similar like Ukraine. But also officially our government saying that we don't have problem with HIV. We have very negative relationship with Polish government, but we are in the top of 10 by UNAIDS report, the biggest number of increase in a new HIV diagnosis, and it was before COVID and it was before the war. So it was also before the situation. We have right now in Poland, we are talking about the timeline, it's before COVID and before war. Foundation for Social Education, as I mentioned, we have working around different topics, but I will today concentrate on our work, especially what I'm responsible for. So it's HIV and AIDS programs. We have 2 VCT centers in Warsaw. We're testing for hepatitis C, syphilis, and HIV. We have mobile harm reduction service for drug users. We have Positive Academy for people living with HIV and their family. We are doing research, advocacy, and social campaign. I mentioned about it because everything what we are doing before war, we open and we must implement for Ukrainian people. So we transfer all our work also to include people from Ukraine. We prepare our staff to help those people. We have translation, and also all leaflets and all information we translate for Ukrainian language very, very quickly. As I mentioned in the beginning, we do not have good situation with HIV. Governmental level, 95% of Polish budget goes for treatment, and everybody who needs treatment gets treatment. But as you can imagine, we don't have money for prevention and support for people living with HIV. And it was before the war, and nothing more was changed by the government. And also we have very low level of testing. Around 10% adult people in Poland had ever tested in their life. And going to the migrants, I put a question about migrants or migrants, because most of Polish people concentrate about our brave around Ukrainian people, and of course it's true. But also before the war Ukraine, we have still a huge crisis on our board of Belarus, and it was in 2021, and it's still going on. And in this case, we are not so brave. We are still having push-up and pushback going on. We have a huge wall right now was built by the Polish government, and nobody wants to talk about the situation of the people who are try to come to Poland, also from Belarus side, from Syria, Azerbaijan, and other country. And pushback is going on, and we have winter again soon. So it's happened. It doesn't finish. Of course, the Ukrainian impact for the Polish situation was huge, and we were very brave, and we are still brave, and open our hearts for Ukrainian migrants who are coming and still probably will come. But from HIV perspective, we have to still have in mind that the situation in Ukraine are extremely different than in Poland. But from other side, Ukrainians have support from Global Fund and have a huge impact of NGOs, and this support was amazing. I was so surprised when we were in contact directly what is going on, and also it was impact in the Polish reality, because people from Ukraine expect the same support from NGOs like has in Ukraine, and in Polish NGOs it's not so huge support, and patient organization, most of them are volunteers work, is an extra work. Of course, we have the biggest number of refugees. Officially, it's the data from yesterday I checked. We have 1.5 million Ukrainian still staying. Probably will come another wave because of winter time. And 2 weeks ago, there was an EACS conference of standard of care, and Sergei Antoniak present a situation, what is going on in Ukraine. Because in the beginning, we have very good connection with Ukrainian doctors, and the information going back and forth about the patient. But right now, because there is no electricity in the Ukraine, it's very hard to contact by email with doctors, and we know that it's again bombing, and the situation is going worse. And this was shown about the testing and everything going bad in the Ukraine, because it's right now almost 9 months of this war, so everything is changing from negative way, of course. So we have to also have in mind the vertical transmission. I will come back for this topic later in the Polish situation. And it's also the extremely different situation on cascade of care in Ukraine and in Poland. So this data showed by Dr. Sergei Antoniak present also the impact of war on the continuity of art, because in the beginning some people still have possibility to get treatment from Ukraine, and it's going worse. Of course, they are expecting to have this treatment in Poland, and they have. So there is a good cooperation between Ukrainian doctors and European doctors. There is a protocol created by WHO and ECDC, EACS, to contact those and transfer the information, to not have lack of the information about the medical history, because we know that some people just taking the small bag and going without any history of the medicine and health. In Poland, as I mentioned, officially we have stable situation. That is official information from Polish government. We have access for treatment. Everybody who needs treatment gets treatment, but we have only 17 antiretroviral clinic, and we don't have STI clinic dedicated for STIs, and we have around 100 physicians usually working in the clinic and in hospital in the same way. So everybody who are coming to Poland have to remember that we are not so big infrastructure, and the number of doctors do not increase even though that we have more patients. And also it's very important that in this region, it's the most important region. We don't have HIV clinic, and most people from Ukraine coming here, it's the first place. It's Przemyśl and Rzeszów. And there is no HIV clinic, so also the patient need to go to another if they need to antiretroviral therapy. And also we have only 5 clinics for kids. And the first one, this is the board for Ukraine, first one is in Warsaw, and second is in Wrocław. So for kids, people have to go 200-300 kilometers to find out the doctor for kids. So it's also the huge solution. And this is what I mentioned, that the stable situation from the government, it's not stable situation from our perspective as NGO, because this is the data from 2021 from Polish, and this is from 2022. So we have double number of cases, new cases of HIV, and also double number of new cases of AIDS. So we are in the top also of late presenters in Poland, because we are not testing. And this is the newest data was presented by National AIDS Center few days ago on the conference that I attend. So we have right now officially almost 18,000 people living with HIV on treatment, and right now around 2,600 migrants from Ukraine. And finally, after a very long time, we have a TLD from WHO. Before that, everything was organized from the Polish budget, and this TLD treatment is very, very supportive for us, and we hope that it will be long-term help. And this is what I mentioned about kids. Officially in Poland, there is around 90 kids living with HIV, and most of them are teenagers, because the mother-to-child transmission, it's not such a big problem in Poland this year, because we have treatment. But only in the 9 months, we have more 95 kids living with HIV from Ukraine, and still we have 5 clinics for for kids living with HIV, and the same number of nurses, the same number of doctors, and extremely different needs of help for kids living with HIV than for adults living with HIV. So this is going to be a huge, huge problem, especially from the medical way. So just very shortly also, we have to remember that Poland government have is in conflict with EU, but we have also not open heart for reproductive health. So Poland is the worst accessible for modern contraception among European country, and gynecologist sector is strong privatized. It's also important that we have very strong abortion law. So in the thinking of the war and rape in Ukraine, there is no access for Ukrainian women to go to abortion in Poland. They have to go to Germany or Czechia. So this is the last one of from the 2021, the contraception map in Europe. And this is also what we know from the MSM population, that we are a very homophobic country, and also government are very homophobic. So also we have to have in mind when we're talking about key population that Polish government do not dedicate campaign for the key population, don't want to even talk about this officially, even National AIDS Center. So this is the number of new patients living with HIV from Ukraine coming to Poland, so the number is going up. And as I mentioned, staff is exactly the same. So also in our VCT center, we're trying to face this situation. We have, as I mentioned, rapid tests for HIV, hepatitis C, and syphilis. And just to show, last night I tried to summarize some data from our testing places to show you also the prevalence of testing for HIV in our VCT center from Ukraine. We have in Polish people around 1%, and from Ukrainian coming for the testing, this number is much higher. So we of course try to share in our information in the social media that everybody can come, and of course Ukrainian people coming. We have also mobile harm reduction service, and the impact of the war, but also from migrants, not from Ukraine, but also from other eastern country, it's very, we see it strongly in this. It's dedicated for drug users, and sorry I didn't translate it, but you can see in our mobile harm reduction service in the last, this is the month of this year, and the number of people from other than Poland countries. And as you can see, the impact of Ukrainian people coming here, but also from Georgia, Belarus, Chechnya and Armenia and other countries. And this is also very important because they are drug users and they don't want to testing. They only coming for needle exchange program. They don't want to talk about testing. They don't want to talk about HIV status. So this is also some kind of barriers, and we see that these numbers growing up. And right now almost half of our clients on the mobile harm reduction service are people from eastern part of Europe with speaking different languages. And just to summarize, of course, we are faced of this situation from the very beginning. So we translate our website for Ukrainian language. We have also a dedicated page for people living with HIV, and it's also in Ukrainian language. But we are also in a strong cooperation with Alliance Public Health, the Ukrainian, one of the biggest organizations, and we are in the hub in Poland with them. So we are strong collaborate, working together and talking a lot from the beginning what to do, how can we support each other. So to summarize, we need a long-term strategy, because we know that the situation doesn't change quickly. Even the war will finish hopefully very quick. The situation with Ukrainian people in Poland and other Eastern Europe country, migrants will coming to Poland and will stay in Poland. So we need to think about long-term action, long-term strategy, and also resource for support NGO, because this is our responsibility, and also we know that we are the main group who are helping people. We have support trainings and cooperation. And it's also a big thanks from my side, from WHO, AIDS Action Europe, Harriet from Germany, and also WIPI and UNAIDS, because you react on the situation and support us very, very strong. And it gives us also opportunity to implement so activities as possible. So thank you for your attention.
Well, many thanks, Magdalena, for the good work that you're doing, but also really for providing us with the data and a rather sobering picture of what's happening in Poland these days. So with that, I hand over to Harvey Kennedy Pitt for a discussion that we have around 10 minutes for. I think you saw that indeed quite a few participants have some questions. So I hand over to you to guide this discussion. I think the mic is coming. Okay. Yeah.
Okay, sorry. I had a question for the presentation before Maga's presentation. Sorry, I'm from ECDC.
Perhaps let Harvey to introduce the session if you want, and then of course very happy to hand you over. So Harvey, feel free to speak.
Yeah, that's fine. So Harvey Kennedy Pitt, from England. I'm the CEO and founding director of Black Beetle Health, which is a Manchester-based charity that supports LGBTQ+ people from racially minoritized backgrounds. I'm not going to reflect on the session because there's going to be a session for that, but I think we can just carry on the conversation, which I'll mediate, take some questions and just guide the discussion. So if you want to just hit off with your first question, but just acknowledge that there will be other questions as well within the 10 minutes, okay?
Okay, thank you. I'm Adama. I had a question for the previous speaker. I was interested to know, you mentioned that Adama from ECDC, I'm the project officer for ECDC on quality of life and mental health. I was interested in finding out, you said when these people are not, most of them are in the streets, what's the data? How many women, children? I may have missed that in the presentation. Is there data on how many women and children would actually sleep on the streets? Thank you, and what's been done?
To find women is very rare. They are male and they are minor. Minor, I mean, they can be 18, 19, but they say 17 probably, but that is the main age. Male, young men. But there are also people, it's a reality. They are there on the street since 15 years. They are 55. These are from North Africa, mainly.
Okay, brilliant. And that can be from any session across this morning's activities. Yep, Ian.
Good morning, everyone. My name is Ian. I work for Open Paths. I have, I think I can link my two questions. One is directed to Taimur, who is not here. Okay, and basically it had to do with data and how ECDC can provide data that is difficult for us on a national level to gain access to, so we can use it for support. And then the second question had to do with Luciano. He mentioned that according to Taimur and the ECDC reports that were presented to us today, migrants, from the data we see that migrants are contacting HIV upon arrival in the EU. So I would like to recommend and also supplement to what you said, that at the reception centers there should be the educational materials, informative materials, and also preventive materials, so that the people should know from the beginning that this is here, and they can know that they should take care of themselves from the very beginning before they step into Europe. That was what I wanted to share.
Yeah, so just to respond to the question aimed at Timo, he had to catch a flight out because he's got another meeting, but he asked me to inform everyone that if you need any data for your country, for advocacy, you should let me know, or you should let him know. You can actually write to us, and we can share his details with you so that he can give you that information directly. And he also asked if there are any questions related to the work he's doing or the presentation, that you could send those to us and he will respond to you directly.
Any other questions?
as I said yesterday, these people on the street, they are invisible for the public services, but they are really visible for the criminal organization. So they are involved as soon as in dealing, in selling drug and in the sex market. So this is the way they become positive, because when you sell drug, this is the story of drug users. You start selling after you become user and after you become abuser. And this is the main way to get HIV. And as you know, most of the African from the sub-Saharan area, they drink a lot. They go on drinking beer. So this is the main way, not drinking beer, but drinking beer plus crack. They become very vulnerable for HIV. The one who are involved in the sex market, we discovered that some people, men, they are involved in the group session of the Italians, and that is a very risk behavior to get HIV.
Okay, Maura.
Thank you so much. I just wanted to comment on what Ian has said. I mean, from experience, speaking from experience and speaking about Germany, example where I live. Example, when we talk about migrants lack information at the reception centers, I mean, in most of the time from experience, they have the information about HIV and infectious disease and so on. But what we have to know is also they're exposed based on the status, which we were emphasizing since yesterday to date. It's because of the status. Because I remember when I arrived in Germany, example, at the immigration office, they would tell you, in order to stay in Germany, you have to have a baby with a European or a German citizen, or you marry. So imagine you come at this moment. I mean, thank God I didn't have a baby to get my status. But there are hundreds and thousands of people who are every day and night going to clubs on the streets looking for women to sleep with them and to have baby. They are doing it out, they know the risk, everything. They know, they have the knowledge and everything about the risk of not protecting yourself and so on. But all what they want is the status. They want to sleep with anyone they meet on the street, to have baby, to have status, unknown people without even knowing their status. So all these problems we're talking about, it's all about status. They can be prevented if they have status. They will not be exposed into that. But it's based on the status. This is big problem. Speaking about Germany example, right now, even though right now, every day young men are going hunting on streets and clubs to find women in order to have the stay. And they are meeting people outside randomly in the parks where I walk, people who do not even know their status. They do not even know them. They just meet one night and sleep with them. In most of the time, they come to us, I slept with someone 2 days ago, and then I've been exposed with this and this. We realized that it's either, STI or hepatitis or whatever. So far, we had never tested HIV, but maybe this on trend. This is coming. So just to put addition to what you have said.
So much for that, Maura. I think it's interesting to look at the impact of desperation in the wider picture. It's not out of lack of agency or necessarily lack of understanding, but it's just show desperation. Susan, did you have a comment? And then we'll come back to Jacqueline.
Hi, I've got a question for Magdalena. Magdalena, do you find that the treatment of migrants from Ukraine differs to how migrants from the Middle East and Africa are treated? Because I think that's certainly something that we're seeing in the UK.
The answer is no, because Polish guidelines have individual treatment for everybody. The problem was that 80% of Ukrainian people use this TLD. 80% of Ukrainian has only this one treatment, TLD, and it was not available in Europe because it's Indian generic. So all Ukrainian people and all people coming to Poland and have access for antiretroviral treatment have access for all drugs. Poland is one of the, in this part, I think, the best country in Europe that we have access for everything, and the decision is going from the doctors, from clinicians. So we have right now even implementation of long-acting injectable treatment. So it wasn't a problem with treatment. The problem was that, first of all, for what should be switched if we didn't have some component. For example, Truvada was finished quickly, and then what to do if we switch for this treatment when those people need to come back to Ukraine because they will need again switch the treatment. So this was also the discussion from clinician how to switch to be safety, and but it wasn't the problem with treatment. The Polish government spent a huge amount of money to buy this treatment and get treatment, and so it's not different between treatment for migrants and for Polish people. It's exactly the same.
Was that your question? Yeah,
That wasn't quite what I was asking. Sorry, I think I should have been a bit more clear. Sorry, I meant in terms of, is there more hostility?
Oh, about treatment between
yes.
Sorry, the problem is with war migrants have special issue, so they do not any documents if they or anything, that there are war migrants, they have access for everything. Other people need insurance. So this is the problem. Treatment is for everybody, but healthcare system in Poland is based on insurance. So you cannot go to the doctor and take pills. Pills are available for everybody, but to take these pills you need to have a visit. And to have a visit you need to insurance. So this is the problem that we face from years. And right now also National AIDS Center try to change the law that not only the antiretroviral treatment is without insurance, but the visit for antiretroviral treatment should be out of the insurance. But it still exists, and yes, it's the problem, and it was problem for those people for what I mentioned at the beginning, that we and they stay in Poland, so they were not war migrants officially, so it was also the problem what to do with them. So yeah, this is the solution with, for example, Georgia people who are coming to Poland and they're illegal. They need somehow help to organize the insurance to go for HIV clinic.
That question there, just to make sure we've clarified the answer to your question, the difference between Ukrainian sort of immigrants and non-Ukrainian, say, coming from sub-Saharan Africa areas, is there a differentiation in the treatment they receive? So the answer sounds like it's yes, and that's based on being a war immigrant or being a non-war immigrant that requires insurance. So there is a difference. Is that what we understood there? Yeah. Okay, Jacqueline.
Thank you very much. It's more of observations. So I note the point that those from sub-Saharan Africa do drink a lot of alcohol. But let's put this into context. You know, Germans and Belgians drink a lot. So I think it really does require an element of balance. And as we mentioned today, there is trauma involved. So all of this behavior is dictated by their life experience. It is to numb the pain. There's also been an observation about the fact that some migrant men may be looking to become fathers to secure their status. I would like to highlight that it's some. I think it would be a distortion to have a picture whereby all or a majority of black migrant men are looking to become fathers. So yes, this is true, but everything is about balance. I must also note that whilst they're doing this, they're having intercourse with European people, men, women, or those who, you know, so again, that is willing. And perhaps what we should note here is that there's a risk to the migrants and also to the natives. So, and this may be the unlocking, I think, in terms of looking how to approach and lobby government, because this is intercourse between those who are migrants and also those who were local. So whilst we're here talking about the migrants, this is a risk to all involved. And we're in a position whereby we do hope that in the near future, this will be a problem regarding everybody and not this little siloed ghetto thing about looking at migrants, which affects everybody. The consequences are far-reaching for the entire population. The question and observation about difference in treatment in terms of Ukrainians and non-Ukrainians. I am going to be absolutely blunt and speak from my own experience as a human rights lawyer and activist and somebody working within the community. In the United Kingdom, it was traumatizing to see the response to the Ukrainian refugees. Yeah. We all want to support refugees from all parts of the world. So I have to caveat it by saying it was not trauma by seeking support for Ukrainian refugees, but it was the disparity between. And the only example that I can give with regards to this is that for Ukrainians, we're offering you a home in our house, and we'll give you a stipend to support them. For non-Ukrainians, we're looking to fill you up in an aeroplane and take you to Rwanda. And whilst this would affect general immigration status, I think there is no jump to say that then access to medical care will be under the same lens. So I am seeking to be blunt as possible so that we can really address this. And I say this as an opportunity. Having realized the disparity, what do we intend to do about this? Because all humans matter regardless from where they come from. All migrants matter regardless from where they come from. Healthcare should be universal. Thank you.
Hello, everyone. I am Matiosa from Cyprus, Generation for Change CY. I have a question for Luciano and any other organization on the field providing psychological support and services. My question has to do with, is there any particular pattern or symptoms or psychopathology that are common when it comes to migrants and refugees diagnosed with HIV?
With HIV?
Yes.
Might we be able to take the second and last question that we can probably try and combine them in the answer? So Ben, I don't know, Ben, you could ask your question and then we can try and pick both of them up at the same time.
It's a very simple question. The UNAIDS representative this morning used the term forced migration. Yeah. And it's the first time I heard that in the 2 days. Do people not want to use that terminology, or is it just an oversight that we didn't talk about it? Because I think, going back to Susan's points that she's been making about the right weaponizing the whole issue of migration, so many of the people are migrating because of the actions of Europeans and Americans, that these people are being forced into migrating because of wars.
So we'll take a response from Luciano and then we'll go back to you, Gary, for the second response.
The only thing I can say is that one cause of immune compromission is depression, is anxious, are mental problems. Normally, this problem acts as immune suppression. So if you get HIV, probably the time to go towards AIDS is shorter than the normal one, but there are no symptoms, particular symptoms that can be addressed to migrants. It depends the status. If it's, malnutrition is another cause of immune compromission. So if we have all these causes, probably, because today, a European one with AIDS, it's not like in the past. We had 5 years to go to AIDS. Now you have 5 to 30 years to go to AIDS because the virus is quicker. So if you put together other causes of immune compromission, of course. So if they stay on the road, if they have mental problems, is easy that they progress to AIDS in a shorter time, but are not symptoms of HIV, are symptoms of opportunistic disease.
Okay, and Gary, just to respond to Ben's question.
Thank you. Yeah, no, thanks very much. We, excuse me, we borrow that terminology largely from IOM, International Organisation for Migration, as well as from OCHA. It's simply the two of the numerous classifications of migrants, if you will. The two big ones, one is voluntary migration, where somebody goes of their own free will and there's absolutely no force or coercion. The forced part comes in, for example, if you're caught up in violent conflict, a civil war, climate disaster, you've lost everything in a flood or a fire or a drought. You belong to an ethnic minority, for example. You fear for your life and you have to run as fast as you can. That's the forced migration. So it's just to make the point that voluntary, that's different altogether. The normal routes of migration, that includes such things as students, for example, seeking education in another country. The forced part is when you have absolutely no choice but to survive, you have to go. Thank you.
I'll hand back to you, Elizabeth. There is one other question if you'd like to take it, which is Ian, but I'm handing back to you now. Thank you.
My response is to Etiosa. In terms of mental health, because I practice mental health on HIV positive people in the community, we tend not to classify or to try to put people with symptoms, because each individual has a different way of coping and has a different resilience system. So you cannot use a one-size-fits-all specifically for mental health. You just need to accept what they bring and go with what they want to work on during every session. That's the only advice I can give you from my experience from the field.
You need to offer the test. You need to offer the test.
No,
they don't have any symptoms.
No, I meant for the people, his question was for the people who are already positive and they know this and they come for you for mental health support. You just need to go with what they want to work on and drive through that.
Good. Well, many thanks, Harvey. I believe there's perhaps more questions, but we have lunch soon, so I'm also sure that on a bilateral basis you still can continue discussing, really. I'm going to go to Ferenc for a summary. I already saw you there, so great indeed that you will give us a brief summary of the key points, which is probably not an easy task, because I think we have discussed a lot. But over to you, Ferenc, for a short summary.
It's actually here. Hello?
Yes.
Thank you.
This one.
Thank you so much. Yeah, it is very difficult to sum up what we just were talking today, but as we are at the Mind the Gap Summit, I really want to start with the gaps that were mentioned today. I think that was the kickoff of the meeting presented by Taimur and other presenters. Very concerning that there is lack of data, so there is data gap. And even from this lack of data, what we heard today, what we received as information is that there is a prevention gap, testing gap, treatment gap and stigma gap in Europe, in the European Union, looking at migrant communities. Then we also heard there is research gap from the Fast Track City presentations, not knowing enough about the complexity and the multi-dimensional, multi-level complexities of the communities we are working with. From WHO, what we heard that there is a gap in implementation. The recommendations are not taken up by the countries, and even if they are taken up, they are not implemented. So the guidelines and recommendations gap is very concerning. And of course, we heard funding several times, not just today, but yesterday as well. So there's a huge funding gap in reaching all those targets that are in our different strategies, action plans, and also the SDGs. My second bigger point is to heard action is needed. And I really liked what Luca was saying about the lack of political will and how we need to be political involve ourselves in policy work and work with politicians. Yeah, it shows, engaging in policy work with politicians, it's not easy. But I just wanted to reflect to two topics that was brought up by the European Commission's DG Santé representatives, and these are the thematic networks that is just being launched. One of them is coordinated by the Civil Society Forum. It is looking at HIV, TB, viral hepatitis, and STIs in Europe, and focusing on access and availability, criminalization and legal environments, cross-border healthcare, which is very relevant for the topic of migration, and stigma and discrimination. And there are other three thematic networks. One of them is called DISCO. It is looking at discrimination, specifically on racism. So I really encourage people at the table to engage with these networks. There is one on mental health, which is also very relevant from the migration point of view, and there is a very interesting thematic network on artificial intelligence. And during the kickoff meeting, it was already brought up whether artificial intelligence in healthcare services might increase inequalities, looking at poverty and other access issues. So I encourage everyone to engage with these thematic networks. There is hope that what we are saying and our statements will be read and hopefully taken up by policy and decision makers in Europe. And finally, I was very happy to hear and see on the screen the Universal Declaration of Human Rights from 1948. It's going to be 75 years old next year. And also the gap, how we are not, the commitments are not lived up. We need to keep our decision makers and our elected officials committed to these human rights. There was the Article 13 freedom of movement today, but also from the UNAIDS representative, we could hear about the right to health, and also in a bit broader sense, the right to universal health coverage, because without that we cannot end AIDS, and also we saw from Professor Lazarus's presentation, we cannot end other pandemics either. And just as I was thinking about this human rights declaration, I wanted to bring you to Article 1, which is talking about that all human beings are born free and equal in dignity and rights. And it was very, very concerning to hear from UNAIDS representative about the subhuman conditions that most of the migrants are, regardless of the phase of migration in transition on the road, etc. So these are my key points. I'm probably, it's very biased because it was what I was listening to, but I want to thank again to Dennis and all the team to put this summit together, and we were very happy to be part of it from AIDS Action Europe, and looking forward to further collaboration. Thank you.
Well, many thanks, Ferenc, for summarizing this morning so well. Not an easy task, but I think you included a lot of the main elements that came to the table. Gary, we started with you this morning, and we said that we wanted to be very concrete, really in translating the bigger picture to concrete action. So in that respect, I'm very keen at the end of this session to hand over back to you with a call for action.
Thank you very much. I did have 10. The 10 has been reduced to 2. So in 2 minutes, again, to thank everyone wholeheartedly. And in terms of call for action, thank you, friends. That was a fantastic summary, and I think in many ways that points us in the direction that we need to travel. So I'm just going to as we do that, and when we talk the right to health, inclusivity, the fact that we are all born equal, these platitudes we've been saying since time began in many ways, How are we going to make that a reality? It, of course, starts, and I'm just stating the obvious, with you and I. It starts with us in this room. And in terms of philosophy, if you want it, remember the universal principle, do unto others as you will have them do unto you. I think that's just a simple thing of when we talk of migrants, when we look at someone sleeping under a bridge, living rough, taking all sorts of risks, they haven't eaten in 2 or 3 days, or it's out of a garbage. Think of how would you feel if that was you. I'm as guilty as the next person, but I should be reminding myself, as we all should, how would we feel if that was us? And so when we talk of the grand plans, it's our own personal action. We hear this a lot with domestic violence and talking grand plans of ending gender-based violence. What happens in your household? What's happening in your thoughts? What's happening? That's where we need to start and we need to finish. It's us and what we do. We can shout to our parliamentarians, as indeed we should, to get the enabling environment. We need that. We need to have a playing field which we can move. Yes, absolutely. And a concerted voice, such as those here. We must also realize that that's at one level, but where does the rubber hit the road? It's in the communities. It's the fantastic work that Magda and her group is doing, and so many others here. It's the day-to-day actions. It's the community spirit. And for me, what can we do? What can I do? Is do whatever I can to get behind that community spirit. We don't create it. It's within us. It's already there. It's human decency. And to close, when we talk of human decency for migration, we need to dignify healthcare for migrants. If we dignify healthcare for migrants, then as a matter of course, it's free and fair access to sustainable services. We dignify the person living with HIV. We dignify the person seeking an HIV test. We dignify their choice, their sexual orientation. We dignify this. We don't hold judgment. And again, it just comes down to do unto others as you would have them do unto you. You don't want to be judged. Lord knows I don't want to be judged. So I have no right to judge others. We need to take that judgmental, moralistic position out, in one sense, and we need to replace it with the morals position is to dignify the health for all. My 2 minutes is up, and there I'll finish. Thank you.
Well, many thanks, Gary, for that very powerful call to action. With that, I would like to hand over to Dennis, because Dennis, I know that indeed before we go to the next room for lunch, that you would like to say a few closing remarks, and thank you. I'm sure there is a mic left somewhere.
Well, the mics keep ending up this end. It sort of gravitates.
Thank you. Okay, is it? All right, cool. So I got a few quick notes. So first of all, just to, here? Great. So first of all, just to take this opportunity to thank you again for those who have spent the previous 2 days with us, but also the delegates joining us today. I know everyone is quite busy and it's not easy to spend a whole day or even just 3 hours on matters such as this. So really thank you for that. Elizabeth, thank you for chairing this session perfectly. We've met with Elizabeth at EFG in Gastein, the European Health Forum Gastein, and we've recently seen the need to work with the organization, especially as we try to advance some of the issues for migrants and the policy issues related to that. So thank you for sparing time to come today. I just want to thank UNAIDS. Gary, you've been with us throughout since we conceived this idea, so really, really want to thank you. for the time that you've dedicated. And also, friends, AIDS Action Europe is a huge organization. We recently got a good funding from European Commission as a partnership. Many organizations here are represented. So we are going to work on some HIV work for marginalized population. And of course, everyone recognizes the work AIDS Action Europe does. So it was great to have, AAE as a partner. I also want to thank IAPAC. Gonzalo is here, who is the president of relations for IAPAC. Jose has been very supportive of the issue of migrants. As you know, fast-track cities are where migrants end. So thank you so much for the work that you're doing, and also we are very proud of the collaboration with you. And of course, I'm not forgetting our facilitators and speakers who have done an excellent job over the past 2 days. So thank you very much for that as well, and we want to continue involving you and to help you, to ask you to help us shape the program as we plan for the next summit. I also just want to take this opportunity to thank my team, Anna, Amy, and Judy. If you may please stand up just So I've been harassing them every day in morning hours, what are we doing today and all that. So Anna's been running around, so thank you so much. Just also to thank our media partner, the wonderful gentleman, I just don't remember the name, but the team after 2 days, and the wonderful lady at the back there, Dasme is a good media company that has really given us so much over these 2 days. I think that we're really proud to have been introduced to you. So thank you also for the work that you've done. And of course, I'm not forgetting our funders. Gilead Sciences has largely funded, has actually sponsored this program, this summit particularly. But we also want to thank VIV because they contributed as well to the summit. And also we want to thank MSD. MSD is also supporting our Mi-Health partnership, and as well as Open Society Foundations for the funding that we received to run Mi-Health. So just to thank them for that. And also, finally, just to say, for delegates who have joined us today, for anyone who don't have their contact details, we'd like to request you to contact details so that we can be in touch with you. We are planning a parliamentary event early next year, but we're also planning another summit, this summit next year. So we would like to have a better preparation and make sure that we have the right people in the room, and it will probably be bigger than this. So we would like to continue getting involved and engaged with you. So please leave your contacts behind. And I think that is it. We're going to have lunch. Please make sure you have lunch before you go. But before that, someone has reminded me that we need a photo operation here. So it would be good to have that. But again, I just want to notice, to recognize the steering committee. We have a steering committee composed of Ben here. Ben Collins has been great supporting us. Christian Noslinger, professor from ITM. And she's sitting somewhere there. Christian, and we Cham, of course, who is not here, who has not been with us today, but also Gary, who was part of the steering committee. So thank you for helping us put together everything. So really, that's all I have for today, and I just want to say it's been lovely and a privilege sharing this summit with you. And I hope for those ones who are traveling today and tomorrow, have a safe journey back home. But before you leave, I've been reminded that we need a photo opportunity here under that banner there. So if we can just, as a group, try and find a way of standing on this platform and having a photo, and then you are free to go for lunch. And finally, reimbursements. So reimbursements are going to be done. If you have any expenses that you've incurred in terms of receipts for travel and everything, please make sure that you get reimbursed before you go. So Anna and Amy are going to be handling that. So photo opportunity here. Thank you.
Tall girls at the back.
Yeah, sorry. Here, coming out. George's fine. It's I need to go. Everyone come. Unfortunately, I need to go back.
Here. Somebody just stand in the room behind you. There's room for tall ones there underneath. Yeah. And then we do another round of. See if you get a lot of tall boys though. This team here, there's nothing. The tall boys behind you. I've got tall boys behind you. See if I do it here. See there. So why don't you see tall boys stand in front of the chairs. There we go. And then you're over.
I'm going to use that.
That's like young people with good knees on the floor.
That's true.
Yeah, with good knees,
Why? Just there.
Okay, and we're going to take the photo with one background and then we'll change the next one. Okay. So just okay.
Judy.
Yes. One. Don't move, please. The other one? You have another? Put the projection. Just projection. Be careful as well. Don't close this one.
STIs.
Simon, we're going to go to the
Yes.
It's for the sponsor.
No one. Yes.
Okay. Okay. That? No, they change.
Yes. Move it, please.
Okay,
Yeah, because you have the.
Then this is for the 16th of May. Yes, the 16th of May is the Day of Living Together, International Day of Living Together in Peace. And the 17th of May is? The 17th of May is?
The day after.
The day after? Yes. Is the International Day Against homophobia.
Transphobia.
That is very, very important. Then we sent for the internet officials a selfie. Yay! Thank you very much.
Come on, Nana. Come on, Mum. Come on.
Sorry, you know why?
Send me the photos from yesterday.
We need a picture.
From the group and now.
No problem, I have it on. Whose phone is our phone? Whose phone? Moro, I will take mine. Oh, okay. Yes, because no, we send it to me. Yes, yes. No, the light. The light. Light? Yes, yes. The beamer? Yes. No, okay. Just that one. Yes. You want to off the light. Okay. Yeah, better. Great. Really great. Okay, where you come? I was coming to it. Yeah, thank you. I'll give you my voice up on So, thank you so much. Yeah, we'll be in contact. Yeah.
Thank you.